Hello. A very good morning, respected seniors, friends, and dear colleagues. I welcome you all for today's CME on the topic which you are very important in day-to-day practice. Nuances in Caesarean section, selling through challenges. I also welcome all the delegates who are attending online. C-section is the most commonly done surgery in obstetric in day-to-day life. Access to safe LSCS is right to every patient. But you all will agree that every section is something new and with surprises and challenges. On this note, we move on to our first session. I will hand over to Ketki now.
I call upon chairpersons for the first session, Dr. Sadhana Desai Madam and Dr. Ashwini Pawar. Sorry, Dr. Sadhana Deshmukh Madam. Sadhana Madam, she is a consultant at Suyash Nursing Home and a consultant at Ashwini Hospital. Dr. Ashwini Pawar is a consultant gynecologist at Omkar Nursing Home, Sunrise Hospital and SIMS Hospital. Over to you, ma'am.
Good morning to you all, respected and honorable guests, my dear respected teachers and my dear colleagues. We'll start with the first session. I think this is very close to heart topic when during a cesarean section something goes wrong, in the OT we get panicky and all those things happen. So this is a very nice selection. Let me welcome Dr. Pushpa Agarwal for her talk. You all know she's a very well known person. She has been a professor and head of department in the VM Government Medical College from 2009 till date, and currently she is a professor and HOD at the Government Medical College, Usmanabad. She was also an acting dean of VMGMC. The most important thing, she has a great contribution. She was a pioneer in managing critical COVID patients and providing ventilatory care during those early days and struggling hard to get the things, material indented in the government hospital for, coping up with such a load of COVID patients. She possesses a great academic background. She was examiner for long years in the anesthesia department. She was vice president in Maharashtra chapter. There are various papers to her credit in national and international conferences, and she has received various awards. One important thing I would like to tell you, she is a gem of a person, and she is a trained yoga instructor and a very senior yoga instructor in art of living. So I think all of us, those who have not done it, we can go to her and she can train us for yoga, meditation, and which will help us to be cool in OT. I think that. Okay, ma'am, we welcome you and you can present your talk.
Good morning, everyone. Respected today's senior faculties in this hall, President of Obstetric and Gynecology Society, Solapur, Secretary, special thanks to Vivek and Meena Madam, giving this opportunity to be say few things in front of obstetrician. Usually, I am with 3 to 4 obstetrician daily, but today, with 200 obstetrician, 1 anesthesiologist, so I have to fight, I have to put my words strongly. I would like to thank Dr. Sadesai Madam, because always I'm blessed by her. I work with her, and her dedication made me to put my efforts in anesthesia. Thank you, madam. And today, anesthesiologist was on right time, 9:30, so there was delay from the obstetrician. I work in Dr. Bhim Government Medical College, since PG and as a academics, that is teacher also. This is the data of this year from 1st January 2023 to August 31st, that 2,972 LSS that happened. Out of that, 2,897 under spinal. I think those who are online and in this hall all prefer spinal anesthesia. That is the first choice. And total number of general anesthesia were only 75. And when there was a contraindication for the spinal anesthesia, general anesthesia was given. We chose spinal anesthesia because it's very simple technique, speed of induction, reliability, less exposure of fetus to multiple drugs, patients are awake, and of course there is a minimal hazards of aspiration. What happens in a spinal anesthesia? Because some side effects are there. There is a sympathectomy that causes hypertension, there will be bradycardia, sometimes high spinal occurs, total spinal occurs, there will be respiratory paralysis. Because of the hypertension, patient may have a nausea, vomiting, and more problematic, the retching when surgeons are going to remove the baby. That is very difficult for the surgeons to take out the baby. Chances of the aspiration even in a spinal anesthesia can occur if it is a very high. Sometimes regional anesthesia get failed and inadequate pain relief is there. And there is a dilemma whether we should continue with the general anesthesia or spinal anesthesia should get repeated. Sometimes headache can occur in the patients, and very rarely that is neurological deficit. But we are, as obstetricians, mostly worried about the hypertension, respiratory paralysis, nausea, vomiting, intraoperative. The key question is that, do we have time for the spinal? Is there any absolute contraindication for the spinal? Yes, if you are having time and there is no absolute contraindication, definitely each and everyone will prefer spinal anesthesia. We have to be considered there are some absolute contraindications. When patient refuses, I don't want, even patient is fit for spinal, patient refuses, we can give general anesthesia. On the last slide, I will show you that all critical patients where general anesthesia was given and we managed in ICU, outcome was very good. So we don't have to worry about the anesthesia. A person behind the table, anesthesiologist, is confident, patient will be definitely come out of the general anesthesia also very nicely. In the conditions where the uncorrected hypovolemia is present, clinical coagulopathy is present or infection at the site of injection. Some related contraindications are there. It depends upon how surgeons and anesthesiologists discuss. If there is spinal deformity is present, spinal cord diseases are present, back problems are present, laboratory coagulopathy is present, a patient in a septicemia or like bacteremia is present, and the chances of the potential hypertension is or hypovolemia is present, like central placenta previa or abruptio placentae, stenotic cardiac valvular heart diseases, or severe pulmonary hypertension where it is a relative contraindication. Why I am telling us a relative contraindication? Because some cardiac nowadays, in a mitral stenosis type of the cases, when patients are taken for this disease, I am giving a spinal anesthesia in low dose. And definitely the expert obstetrician, they are taking baby out within 15 to 20 minutes, that is surgeries get over and without any change in the hemodynamics of the patients. So nowadays all the mitral stenosis, critical mitral stenosis also, I am giving spinal anesthesia. So it is a related contraindication. Yes, when we give anesthesia, some specific skills are required. At the proper time, hemodynamic intervention is required. We should know what vasopressor should be used, what are the antihypertensives that patient is taking or what we should give. Fluid resuscitation, what type of the fluid should be given. If there is a respiratory emergency is there, we should be able to ventilate, we should be able to intubate. If seizures are there, we should immediately, we should manage. Suppose preeclampsia patient, we are giving a spinal, at the same time patient had a convergence on the table, we should be able to manage that one. If morbidly obese patients, then we have to be technically perfect for the spinal management of respiration. And when we are using a uterotonics, we have some knowledge what happens with this uterotonics on the cardiovascular systems. So most important, cesarean section, usually patient that is some newborn baby is coming, this is not the disease. So strike a balance between the happy event and the risky surgery. Hypertension can be as high as 80%. When we label as a hypertension, it decreases less than 100 millimeter of mercury or more than 30 millimeter of mercury of pre-anesthetic value. Basically, hemodynamic changes are because of the three reasons. First is a blockade of the sympathetic vasomotor activity. Second is a compression of the aorta and inferior vena cava. And third is because of the spinal anesthesia, when Benbridge reflex occurs, that causes a severe bradycardia and patient may end up in hypertension. So sympathetic supplies to internal organs are present to veins and arterioles. So these get dilated and venous return is decreases. So these capacitance vessels that get dilated. Aortocaval compression, you can see in a supine position, there is aorta, and when get compresses, venous return decreases, cardiac output decreases. When we go with the left lateral tilt, definitely patient, that is aortocaval compression will get released and increase in the cardiac output. So whenever maternal hypertension occurs, immediately before maternal hypertension, we can see on that is 100 or 90, patient complain about the nausea or vomiting. So continuous monitoring of the patient is very, very important. When patients start complaining, I'm not feeling well or nauseating, immediately you have to be alert. Sometimes there is a bradycardia. Pulse bradycardia means the patient pulse is 60 and it remains 60, it is not a bradycardia. But patient pulse is 80 and pulse is decreasing from 80 to 70 and 60, then that indicates there is a bradycardia is happening. So bradycardia and cardiac arrest can occur. Uterine blood flow is pressure dependent, as there is no autoregulation of the placental blood. And this is important because whenever hypertension occurs, circulation to the placental blood flow is going to be decreased. So as a consequence of this, prolonged maternal hypertension can cause uteroplacental insufficiency, which is damaging to the fetus. Brief episode of maternal hypertension have a lowered Apgar score, prolonged time to sustain respiration, and prolonged fetal acidosis. So we have to be particular and continuous attention has to be there. Anesthesiologist should not be away from the patient's head with the complete monitor. This is very, very important in LSS because each and every step from starting from the spinal given, incision is taken, baby is taken out, uterus is taken out of the abdomen, and then they are going to the suture and PPH occurs. So each steps from starting incision to the end suturing is very, very important. Factors associated with the increased risk of hypertension after spinal anesthesia includes dose of the local anesthesia. So I said that nowadays I am giving low dose for the cardiac or disease patient. So when cardiac patient we can do under the low dose, then why not the normal persons? Why unnecessary we should expose to the patient for the high dose? When go with the high dose, it can spread cephalic, that can cause hypertension, that can cause respiratory problem. Patient's respiration may not be good, there will be tidal volume is going to be decreased. And tidal volume going to decrease, that cause the decreased minute ventilation and hypoxia. So in cases where the already sympathetic tone is very high, like toxemia pregnancy, when we go with the lower dose, chances of the severe hypertension can occur. So most important that we have to prevent the hypertension in cesarean section. That is the first role of the anesthesiologist. Right dose in right space that should be given in a right patient. Second, to treat the hypertension. So most important, that is get a pressure of vena cava by giving a left uterine displacement. Second is a fluid loading. Fill the capacitance vessels that are get dilated, that may be with the crystalloids, colloids, that we can go with the preloading or co-loading also. We'll discuss about that. Third is the arterial constriction is, we have to be, these are dilated, so we have need a constriction, vasopressors. So most of the time some people may give a dopamine or something. Dopamine, there is no role of dopamine in these cases because dopamine is an inotropic and there is no question of the cardiac problem. Dopamine should be given only when the cardiomyopathy is present, where heart is not contracting. In all the other cases, we have to go with the vasopressors. And vasopressors like ephedrine, phenylephrine or mephenteramine. We usually discuss with the ephedrine and phenylephrine, but I will tell you that 90% people are using mephenteramine. So both this ephedrine, phenylephrine, mephenterine are useful for as arterial constrictors and venous constrictors. So dilemma, when hypertension occurs, what I should do? Whether I should go with the crystalloids or colloids, with the preloading or co-loading, or whether I should go with ephedrine, phenylephrine or mephenterine. This is a dilemma, what I should do. So fluid and vasopressors. Fluid usually, that is a prophylaxis, we use vasopressor as a treatment part of the hypertension. Preloading, is there still place for the crystalloid in a preloading? The efficacy of prehydration has been studied extensively in the prevention of hypertension following spinal anesthesia for the cesarean delivery, but the optimum types and doses of preload solution remains controversial. So whether crystalloids having a half-life in the vascular space is short. It fails to produce sustained increase in a blood volume. So thus, crystalloid preload had a minimal effect on the cardiac output and the blood volume. So these are the studies, they say that loading is not essential to prevent the spinal induced hypertension. If not a preloading, then co-loading. Hypothesis that crystalloid administration may be more effective when administered immediately following the initiation of spinal anesthesia. It is termed as a co-load, and during the development of related to hypovolemia. So after giving a spinal anesthesia, hypovolemia occurs, so immediately we can start the co-loading with the last amount of the crystalloids. So what about the preload versus co-load? So this study says that crystalloid preload versus crystalloid co-load for the patients undergoing cesarean section under spinal anesthesia, both preloading and co-loading with the 15 ml per kg of ringal lactate solution are ineffective in the prevention of the spinal induced maternal hypertension. Another study says that influence of the timing of the administration of crystalloid on the maternal hypertension during spinal anesthesia for cesarean delivery, preload versus co-load. In the case of using crystalloid for the cesarean, co-load is more effective than preload for the prevention of maternal hypertension after spinal anesthesia. One more study says that prevention of hypertension during spinal anesthesia for the cesarean delivery, an effective technique using combination of phenylephrine infusion and crystalloid co-hydration. To start the crystalloids after giving spinal anesthesia, at the same time give a low dose of phenylephrine, that is 1 to 5 microgram. So meta-analysis of the studies that compare preloading with the co-loading, the authors found that incidence of hypertension was similar with these two loading techniques, and when colloids used, unexpected it occurs, and crystalloid, unexpected, that is hypertension occurs. So whether again we should go with the colloids instead of the crystalloid. Coming to the crystalloid versus colloid, crystalloid is less effective than the colloids in respect of the preventing hypertension. This might be due to rapid redistribution of crystalloid on the administration, and only a small portion of infused fluid is remain in the intravascular space at the time of vasodilation after the spinal anesthesia. So coming to the colloid preload, several groups of investigators have compared crystalloid preload to colloid preload and found that the incidence of hypertension after induction of spinal anesthesia is lower after preload, and this conclusion is supported by the meta-analysis. Coming to the colloid preload versus co-load, several randomized control trials have compared colloid preload to co-load and found no advantage of colloid preload compared to the co-load. So why unnecessary we should go with the preload colloids? When we are giving the colloids, we have to remember that there are some disadvantages of colloids, which includes cost, possibility of the anaphylactic reaction, excessive volume expansion, and may cause pulmonary edema also. I came across one anaphylactic reaction, severe anaphylactic reaction, when in my 1998, something like that. Manual removal of placenta case was there. Patient was taken for the surgery. That was done. Patient had a hypertension. I started the crystalloids and colloids. I started the hemaxil, and patient landed up in a severe type anaphylactic reaction. Complete face, that is becoming like a balloon, and patient landed up in severe hypertension. When I gave adrenaline, patient responded within 30 minutes, like to fuga asto na fuga lagis normal hai to. So I have seen that anaphylactic reaction, and since then I have stopped hemaxil. That is out of my dictionary, hemaxil and jellyfish. So I don't use these drugs. Coming to the low-dose panel, how we can prevent this hypertension? That is the introduction of the low-dose anesthesia with the combination of small amount of local anesthetic and opioids. We can add opioids also. Nonetheless, maternal hypertension not always preventable, and the use of vasopressor is still frequently required. So low dose, we say that definitely I'm giving cardiac cases also. There is no hypertension, there is hemodynamic stability is there, but we have to keep in mind, if hypertension occurs, we have to be there, we have to be treated properly. So, et al. Concluded that it would be more beneficial to use a combination of low-dose bupivacaine preloading with the colloid and leg wrapping to reduce the incidence of spinal anesthesia-induced hypertension in a patient undergoing Caesarean section. Even we can go with the phenylephrine 1.5 microgram per kg, that is as an alternative method for this. Vasopressors for the treating spinal anesthesia, that is, in addition to the marked reduction in systemic vascular resistance is observed, we suggest that arterial dilation is at least as important as a arteriocaval compression in the contributing towards spinal anesthesia. So we have to take care of both things. Maintaining systemic vascular resistance, venous capacitance, and splanting venous tone are very important to prevent the hypertension. Coming to the phenylephrine, is a short-acting. So which drug we should get now? Phenylephrine is a short-acting potent vasoconstrictor that causes an increase in the both systolic and diastolic blood pressure. It counters the vasodilation due to neuroaxial anesthesia directly, restoring baseline blood pressure. Traditionally, it was used as a second-line vasoconstrictor in obstetrics because of the concern that it causes vasoconstriction in the uteroplacental circulation. A number of human studies in the last 15 years have demonstrated that phenylephrine is equally effective for treating maternal hypertension. But another study has found that no difference in the maternal blood pressure, although bradycardia was more likely after the phenylephrine. So patient having hypertension with the bradycardia, then phenylephrine should not be used. With the phenylephrine, umbilical artery pH was higher after the treatment. However, there was no difference in the number of neonates with umbilical artery pH less than 7.2 or Abgar score less than 7 at 1 and 5 minutes. The two recent dose-response studies of prophylactic phenylephrine infusion to prevent hypertension after induction of spinal anesthesia in elective Caesarean section conclude that no advantage of high dose infusion rates compared to low dose. So instead of giving 75 to 100 microgram, 25 to 50 microgram per minute is sufficient, that will prevent the bradycardia. Coming to the ephedrine, it is the second drug. That ephedrine is a sympathomimetic that has a both alpha and beta receptor agonist action and indirectly release the norepinephrine from the presynaptic nerve terminals. Uterine blood flow in particular was maintained more favorably with the beta agonist than with the alpha agonist. Ephedrine thus become the gold standard for this application. Preloading with the crystal along with the prophylactic intramuscular ephedrine 15 milligram 10 minutes prior to subarachnoid block was effectively prevent hypertension during Caesarean section under spinal anesthesia, but it was associated with the greater fetal concentration of lactate, glucose, catecholamines, and thus support the hypothesis that decrease of fetal pH and metabolic effects secondary to stimulation of the beta adrenergic receptor causes best access with the ephedrine. So ephedrine causes the placenta and that stimulate the fetal beta adrenergic receptors. Nagan and Keen colleagues found that 30 milligram bolus of the ephedrine administered over the 30-second following intrathecal injection did not completely eliminate the maternal hypertension. Again, it goes with the reverse, nausea, vomiting, and fetal acidosis. And ephedrine crosses the placenta more readily than phenylephrine. So furthermore, in the view of maternal response to the spinal anesthesia, decreased systemic vascular resistance, increased heart rate, cardiac output, the use of ephedrine with its beta adrenergic agonist property doesn't make sense for the physiological standpoint like in a preeclampsia, eclampsia, toxemia pregnancy. So coming to the phenylephrine versus the ephedrine, phenylephrine is an alpha adrenergic agonist. Its mechanism of action directly addresses the decrease in the systemic vascular resistance following spinal anesthesia. Has a faster onset of action compared to the ephedrine. Infusion lower as 25 to 50 microgram is sufficient. Ephedrine associated with the 5-fold increase risk of fetal acidosis. Ephedrine is more likely to cross the placenta and increase concentration of lactate glucose and catecholamines in the fetal circulation. So what we are using routinely is metterminol. Metterminol is a alpha and beta agonist, can be used for the spinal induced hypertension. Again, colleagues demonstrate that metterminol was superior to ephedrine at maintaining both maternal pressure and fetal pH during spinal anesthesia for cesarean section. So these are the dilemma about the vasopressis. So in summary, fluids, prehydration is not superior to cohydration, implying that any urgent case should not be delayed on the pre-test of the prehydration. Colloid is superior to crystalloid for the fluid management with some recognizable adverse effects. Crystalloid should be administered rapidly at the time of induction of anesthesia. The use of colloid should be considered in a woman considered a high risk of hypertension, not in all cases. One should consider the role of vasopressors along with the fluid used in the management of hypertension. Use phenylephrine if tachycardia. Use ephedrine if bradycardia. Mefentramin is alternative to ephedrine if there is a bradycardia. Use atropine if severe bradycardia or Benedict reflex is present. Coming to the sponsorship with the impact on the respiratory system, normal pregnancy, there is a decrease in FRC, increased oxygen consumption, increased risk of hypoxia with apnea. And if there is a hypoxia occurred, intubation is required. All cesarean section we should consider there is a difficult intubation. Venous engorgement of the airway mucosa, edema of the airway mucosa, and worsening of Mallampati score in the liver. So we cannot say the spinal are always safe. Any complication can occur and we should be able to intubate in the right time. FRC, what is FRC? FRC is a functional residual capacity, is the reserved tank of oxygen during apnea. So pre-oxygenation is to fill the reserved tank of oxygen, and during spinal anesthesia, if we put a mask, 100% oxygen or at least 50% oxygen to the patient, we are filling this tank. So anything happens, we get some time to prevent the hypoxia. Coming to the tank, pregnant mom has a smaller reserve tank than non-pregnant. So rapidly this patient will end up in hypoxia. In physiological changes in the respiratory system in pregnancy, there is a decreased FRC that we discussed previously, decreased oxygen consumption, increased minute ventilation, and decrease in arterial PCO2. High block, always, or total spinal, a patient becomes unresponsive, so always we should intubate the patient. But during intubation, there is some time is required. First and most important, take your resuscitation bag or your bench kit, ventilate the patient on the mask. Respiration is adequate, give 100% oxygen, start assisting the respiration. Assistant can give required pressure and ventilate. Patient sometimes in severe high block, muscle relaxation may not be required. This respiratory paralysis usually lasts for 10 to 15 minutes, so there is no need to give muscle relaxant and keep patient on ventilator. Immediately you can extubate the patient also on table. Coming to the GIT, there is an increased gastric fluid volume, increased gastric fluid acidity, and decreased competency of lower esophageal sphincter. So there is a risk of aspiration. More risk in the general anesthesia, but we cannot say it cannot happen under regional anesthesia. So consider all purchase as a full stomach, and prophylaxis is very, very important. So 0.3 m sodium citrate 30 ml, that is given in the book, but no one gives that one. It increases again gastric volume. Pan, nowadays instead of ranitidine, we are giving a pan that should be given 6 hours per. Metoclopramide, some that is ondansetron that is given, that acts centrally and that is prevent the reflexes. But metoclopramide, that is decreases the volume of the stomach, so content of the stomach. So that is metoclopramide should be given. Now also for each and every patient, I give metoclopramide. I give 1 hour prior. I put in a drip. I give that slowly, and this is very, very good because once hypertension occurs, nausea, vomiting occurs, even we give a ondansetron patient, there is retching is present and it's difficult for a surgeon to operate. So metoclopramide definitely take care of that. So be aware of the high spinal and heavy supplement. There is inadequate anesthesia, sedation, ketamine. In that cases, aspiration can occur. So most important, and the sentence is that never turn your back on the spinal. That is very, very important. Coming to the post-dural puncture headache. So Frequency course with the needle size. It may be symmetrical, frontal or occipital. It is a postural. Generally start at least 24 hours after dural puncture. There is a large needle is taken. So treatment like oral caffeine, fluid, salt, analgesic, or prone position or blood bath that can be done. Coming to the central nervous system, few points I would like to say that decreased dose of the local anesthetic requirement for the regional anesthesia because there is an engagement of the epidural vessels are present. So normally in a normal laparotomy we give 3 to 4 ml of bupivacaine, but here usually given that is indicated 1.8 to 2. I give a low dose in these patients. And second, if drug enters into the cardiovascular system, so local anesthetic toxicity is very high in these patients. So whenever there is a failed regional anesthesia is there, always be honest with yourself, recognize the failure and move to your plan B. You can repeat or you can give general anesthesia, depends upon the condition and your judgment. Most important, monitoring, that is instead of the gadgets are required. The most important, talk with the patient after giving anesthesia. Does her face is like anxiety is present? You can tell patient to take a deep breath that will maintain the oxygenation of the patient. When the patient is squeezing your finger, her temperature of her hand or veins are dilated on hands, whether your hand feels normal, something like that, that indicates there is a high spinal. So red flags that patient complains, I don't feel so good, I think I'm going to throw up. मला कसं तरी वाटते उलटी झाल्यासारखी वाटते जे पेशंट जेव्हा बोलतो टेक इट पॉझिटिव्हली अँड डू समथिंग फॉर द पेशंट. In high block, patient cannot be. So move to the anesthesia mask circle system early. Don't fuss around assessing the patient. Don't waste your time. Most of the times we assess the patient, there is hypoxia can occur. Reassure the patient, tell them this happens and tell them to, with help of the breath, tell them to take a deep breath. Usually intubation may not be required. Ventilate, a patient will start respiration. But very severe patient cannot take any breath, then immediately you can intubate. But before intubation, give 100% oxygen, 3 to 4 puffs, very important. Sometimes patient will panic, shake head and to get a mask of their face because of the hypoxia, because of the hypoxia it becomes very rowdy and we say patient, tu gappa bas, tula kahi झालं नाही आहे. But when patient becomes rowdy or moving ahead, take it that there might be a hypoxia. And sometimes machine is not showing, we say gadgets is not correct and this SpO2 decrease because machine is good. And machine la kaitri problem, patient is good. But it's not like that. Assume accompanying hypertension, give vasopressors as you reach for the mask. As soon as giving mask, give the vasopressors along with that is very important. So in a high block, what happens? There is a hypoxia occurs one thing. Because decreased FRC, patient cannot breathe. 100% oxygen, support the ventilation and then intubation. Stagnant hypoxia occurs because of the hypovolemia, hypertension, decreased cardiac output. So go with the left uterine displacement, immediately fluids and vasopressors. Anemic hypoxia, if patient having a chronic anemia or patient bleeding, that is acute anemia. So always pack RBC that should be given to the patient. This is a data of my critical patients that admitted in my surgical trauma ICU. Total number of the LSS done was 2,972. This is the data from 1st January to 31st August 2023. Total ICU patients were 149. Transfer from the ICU, that is 138, expired only 6. And in these total ICU patients were referred from the peripheral patients already hypoxic also. 4 patients went Dama, discharged against medical advice. 1 patient was sent to the medical ICU because medical treatment was required. So when we put efforts, after all the patients might be critical patient, most of the critical patient might have given general anesthesia. If we put our efforts and in ICU, we go with the proper nutrition along with the everything management, outcome will be good and maternal mortality is going to be decreased or near zero in the future. Thank you for calling for this.
Thank you. Hello. Madam, thank you for your wonderful talk. It was really very informative for us. Does anyone have any questions for ma'am? If nobody has, I have 2 questions.
You are working in a good anesthesia unit, everything is available. What anesthesia will you prefer, like a spinal or patient who had a history of a previous spinal surgery? Which will we like to still give a spinal anesthesia?
Why we should go for the spinal anesthesia?
Yeah, that-
I'm a confident with general anesthesia. In the periphery, voice machine is there. I can ventilate, I can
No, not,
intubate.
it's a good anesthesia. Everything is available, GI, everything. In
I will
that
go with the
patient,
general
will you-
anesthesia. High anesthesia. Already spinal surgery is done. Patients, we have to think the psychology of the patient also. Why we should not think about the patient's
That
psychology?
happens in a practice, that's what
No,
I'm
madam.
asking.
See, if that patient is my sister, I'm going to give spinal anesthesia to that patient? No. I will use general anesthesia.
If a spinal surgery preferred, should
I
be
will go with
ideal
the general
should be-
anesthesia. Why general anesthesia is better, no?
Patient who had a previous congenital heart disease, the patient who already had a congenital heart disease, again anesthesia preferred will be still spinal?
Madam, if congenital heart disease where chances of the right to left shunt is very high with the spinal anesthesia. So if we are giving a spinal anesthesia in that case, we have a phenylephrine that is very important. That drip has to be started. If you don't have phenylephrine in emergency, you can go with the noradrenaline.
But is it the general anesthesia is safer?
It's general anesthesia safer.
Therefore, ideally,
Yes,
should
and
be
the
given,
general anesthesia is
general
safer.
anesthesia.
You can put the epidural for the pain relief, but general anesthesia is safer.
Preferred anesthesia in eclampsia.
Prefer, it depends upon the condition of patient. Usually, I will prefer patient drowsy, patient need a post-operative ventilator, high anesthesia, spinal anesthesia. Go with the general anesthesia. But it is not contraindicated. Eclampsia is not contraindication for the spinal anesthesia. If patient coagulopathy is normal, very well we can go with that.
And last thing for MRP.
Manual removal placenta.
Yes, right.
Madam, manual removal placenta, we have to consider patient's full stomach. All obstetric patient is full stomach, we have to consider. Second, patient in a severe hypertension, bleeding will be present. Third, uterus relaxation is required. In that cases, if we give spinal anesthesia, uterus will not get relaxed, it will get contracted. So anesthesia, there is general anesthesia is required. In the general anesthesia, inhalation anesthetic in a high dose will be required because surgeons will say that there is a bleeding, don't give an inhalation anesthetic very high. But inhalation anesthesia is required. Along with that, you can give a nitroglycerin, you can dilute. You can dilute up to the 20 cc, take a 1 cc, again dilute 10 cc. When you are putting the hand in the uterus, give the nitroglycerin, you can take out the placenta and this nitroglycerin is very short acting and patient will come out of that.
Hello.
Madam, what is treatment for spinal headache? But when we were PGs, we used to give 25% dextrose and head low position. So what is ideal
Madam,
treatment?
nowadays chances of the post-spinal headache is very because when we were doing the PG, we are using a 21 number or 22 number of the spinal needle. Nowadays, we are not using a 23 spinal needle. Usually that is used in orthopedic patients where lying down conditions are present. 25 is sufficient and 25 Vitacare we take, the chances of the post-spinal headache is very, very less. With the 27 number, there is a failure chances is very high. So 25 is the size of the needle, that is very good. In that case, post-spinal headache is occurs. So always keep head low, that is one. Second, give a crystallize to the patient. Adequate fluid is required, adequate hydration is required. Analgesic keep for the 24 to 72 hours. And in that cases, you can go with the prone position if possible. And if it not get reduced after that, then only consider for the blood patch. Otherwise, don't consider for the blood patch.
Here, I would like to ask one question, madam. To prevent spinal headache, shall we use Vitacare needles in all the patients? Because the incidence is almost nil in those needles, rather than plain spinal
Yeah,
needles.
that is, yeah. 27 Vitacare incidence is nil. 25 Vitacare, it can happen. But failure rate is very high with the 27 Vitacare. So always if availability is there, available, we can 25 number, Vitacare is good.
Madam, last, the very simple questions for all. While preparing for LSCS, how much preloading, which fluid we must give? That is number one question. And whether to give glycopyrrolate or iatropine pre-medication.
Nowadays, people are not giving atropine or glycopyrrolate, both they are not giving in the preload, that is in all the spinal anesthesia cases. But we have to take care, we have to be with the patient whenever it is required. Suppose if you don't give any vagolytic, if bradycardia occurs, then the requirement of the atropine is a 2 ampoule. 1 atropine will not take care of that. So keep the 3 to 4 ampoules of the atropine on your table. There is no need of giving atropine or glycopyrrolate in these cases. Preloading. Previously, we used to give 1 liter of the fluid, but nowadays we are not giving. We start with the co-loading, that is spinal. So there is no need of preloading, and there is no need to postpone the case also or delay the case also.
Thank you, ma'am.
No, if patient having that is, you can give headache, paracetamol is there, ibuprofen, so many drugs are there. What totally we take that, take care of that.
Thank you very much, madam. Thank you.
One thing important, when she asked about the headache drug, I remember that analgesic, that is what we should consider after the LSCS. Most of the times we go with the opiates or spinal opiates or epidural or tab block and something, so many things are coming up. But when you are suturing, once you suture the peritoneum, put a 5 cc of Sensoken and wait for 2 to 3 minutes. Bupivacaine, 2% bupivacaine. Wait for 5 minutes, 2 to 3 minutes, and the suture. It's give an excellent pain relief. Because when wound is open, once before closing, put a 5 cc of your 0.5% Sensoken. We should do, because that's very, and it gives excellent pain for 3 to 4 hours. Excellent pain relief. Yes, yes. And there is no need to get tab block or something unnecessary for that. Yes, sir. Madam, the cases where usually patients having no, madam. Short stretcher means when go with the high spinal only. That is there. So in that cases, we have to decrease the dose. Suppose in normal height, we are giving a dose. So in a short stretcher, we can give 0.6 or 0.8. In a heart disease, I said that with the low dose. What I do in a heart disease cases, mitral stenosis cases, I take a 0.8 cc of Sensoken. I dilute up to the 1. Height is very good. Then I take a 1 cc, dilute up to the 1.5 cc. I give 1.5 cc of the dilute with the CSF. Only I withdraw the CSF and I inject that one. In mitral stenosis critical where the diameter is 0.8, in that cases I give that one. Thank you.
Thank you very much, madam, for such an elaborate lecture and clearing our doubts. I introduce our next speaker, Dr. P.K. Shah. He is my teacher also from Caesarean Hospital. He is professor and unit head, Department of Obstetrics and Gynecology, St. G.S. Medical College and KM Hospital, Parel, from 2008 to 2016. He was passed in Indian College of Medical Ultrasound, past president of many societies of endoscopy, ultrasonography. He was past president of MOGS, past president of SOGS. He has, in short, he is a versatile personality. I call upon Dr. P.K. Shah sir to start with his lecture. Thank you.
For your kind introduction. At the outset, let me thank Dr. Virkar and all the office bearers of Solapur OB/GYN Society for inviting me to deliver a talk on a new molecule which we use nowadays for iron deficiency anemia. I would also like to thank Gleason for arranging this program here at Solapur. I have come to Solapur after a very, very long time. Ladies and gentlemen, with time, we have to change our practice. When we got the first house first, way back in 77, laparoscopy had just come. And now laparoscopy has become part of our life and even practice. The same thing is true for management of iron deficiency anemia. To start with, I'll tell you some facts about IDA and then tell you about this new molecule, I3. It is not 13, 3 I's, intravenous iron isomaltoside. 3 I's, okay? It's a game changer. Most common micronutrient deficiency in the world, affecting almost 24% of the world population. Can you believe it? Iron deficiency anemia, 1/4. Something very funny. And in India, we are leaders sometimes. 53% of pregnant women are iron deficient. And in Sayan Hospital, where I spent my 23 years, the figure was almost 63%. Iron deficiency can range from subclinical state to severe iron deficiency anemia. I am not going to go into the effect of iron deficiency on pregnant women like increased maternal mortality, etc., because we are talking on a new molecule today. What are the dietary factors that affect absorption? There are some that enhance the absorption like meat, fish, poultry food products, seafood, gastric acid, ascorbic acid, malic acid and citric acid. Whereas there are some food products which inhibit the absorption of iron from GI tract, and that includes phosphate, calcium, tea, coffee, colas, soy protein, high doses of minerals and bran fiber. So, what is the requirement of iron? I know all of you know this, but just to recapitulate your knowledge. Around 2.5 milligram per day in first trimester. 5.5 milligram, we don't give in first trimester, let me tell you. We don't give it because it causes nausea. 5.5 milligram from 20 to 32 weeks, 6 to 8 milligram after 32 weeks, and on an average at least 4 milligram per day. Ideally, women should enter pregnancy with adequate iron stores. Very important. Not only hemoglobin more than 10 or 11, but the adequate iron stores. As a public health approach, prolonged oral iron supplementation even before pregnancy is a better strategy. And so you must do proper preconception counseling. The World Health Organization recommends 60 milligram of elemental iron with 2.5 milligram of folic acid for 6 months in pregnancy and additional 3 months postpartum. Ministry of Health and Family Welfare, Government of India recommends 100 milligram of elemental iron with 5 milligram folic acid for 100 days in second half of the pregnancy. We all know what all products are available now for us to give orally, like ferrous fumarate, sulfate, gluconate, iron dextran, ferrigluconate, iron sucrose, FCM, etc. But if you see by the side what I have written, the elemental iron available, ferrous gluconate is the worst. So never ever give ferrous gluconate orally. Ferrous fumarate, sulfate, these are the two which can be given easily. But today we are going to talk only on parenteral iron. So basically all of us have given injection interferon. Sorry for saying this name, normally I don't promote. But iron dextran, we have given, all of us have given in our lives. We gave up simply because of many complications that it had, the side effects. You could have, we gave it either intramuscular, nursing staff used to give, or we have given intravenous after admitting the patient. And then ferric gluconate, not many of us have given, but iron sucrose, yes, all of us have given. Thousands of ampoules so far, 20 milligram per iron per milliliter, and ferric carboxymaltose that we are giving now in our practice, majority of us. Iron is best absorbed in ferrous form, we all know that. Treatment should be continued till the blood picture becomes normal. There is a maintenance dose of 1 tablet per day to be continued for at least 100 days following delivery to replenish the iron stores. Very important. Patient will tell you that my hemoglobin level has come to normal. Why are you giving me this Hematinics? So please tell her that it is not only the hemoglobin concentration, it is the iron stores. What are the drawbacks of oral iron therapy? That there is an intolerance, we all know that. Evidenced by pain, nausea, vomiting, diarrhea, constipation. Avoid intolerance. Therapy should be started with a smaller dose, 1 tablet a day, and then it can be increased to a dose of maximum 3 tablets per day. With therapeutic dose, the serum iron may be restored, but there is difficulty in replenishing the iron stores. Response is evidenced by a sense of well-being, which the patient will tell you. Increase in appetite, improved outlook of the patient, and rise in hemoglobin above 0.7 gram per 100 milliliter per week when you give intravenous or intramuscular. We all know the contraindication, the intolerance to oral iron and severe anemia in advanced pregnancy. Obviously, you want the iron levels to come up fast, so you can't give oral iron. Intramuscular route, we all know so many preparations we all know of: iron dextran, the interferon, iron sorbitol citric acid complex, Jectofer. Both these preparations contain 50 milligram of elemental iron per milliliter. What are the precautions? That oral iron should be suspended. For any parenteral iron that you want to give, please suspend oral iron for at least 24 hours prior to therapy to avoid any reaction. The drawbacks of intramuscular iron are painful procedure, chance of abscess formation at the site of infection, discoloration of the skin at the site of infection, and the worst thing which we have seen, the patient come with tremendous knee pains, the joint pains that she comes with. If you see her, you will feel that she has got some orthopedic problem when she is walking to you. So much. And that we could not manage when we were giving this interferon injection. Luckily, now we have better options available to us. So what are the indications for parenteral iron therapy? We all know poor tolerance to oral iron, poor absorption, non-compliant patient, women with moderate to severe anemia, near term, women on recombinant erythropoietin, and we all know what are the contraindications for parenteral iron: prophylaxis, history of anaphylactic reaction, need rapid restoration of iron stores, and presence of active infection. Again, I am telling you, oral iron should be stopped at least 24 hours prior to therapy to avoid toxic reaction, and restart oral iron 1 week after completion of full dose of parenteral therapy. Wait for 1 week after you have completed the full dose of parenteral iron, then start oral iron. We all know this very well. Calculation of dose of parenteral iron, required iron dose in milligram, 2.4 multiplied by targeted hemoglobin minus actual hemoglobin, multiplied by pre-pregnancy weight in kg, plus 1000 milligram for replenishment of stores. What we were taught once upon a time when we were residents, Madam Sardesai, what was required for replenishment of the stores? When we were told it was 500 milligram. It was 500 milligram. Now it has become 1000 milligram. Now imagine if you have to have 1000 milligram for replenishment, which intravenous iron preparation is available that can give even additional iron, which I told you in the first line, 2.4 multiplied by targeted hemoglobin minus actual hemoglobin multiplied by pre-pregnancy weight. So suppose our hemoglobin is 7 and you want to achieve 11. So you have 4 grams, okay? So 2.4 multiplied by 4 is 9.6, correct? Multiplied by, say, weight is 50. So 480 milligram additionally you will require, plus 1000 milligram for replenishment of the iron store. So that means 1480 milligram you will require for that patient. I hope it is clear. Remember replenishment. So the parenteral iron therapy, we all know first generation, iron dextran, second generation, iron sucrose. I am just talking about products that we have used ourselves. Sorry. Third generation, ferric carboxymaltose, and now this molecule I3 iron isomaltoside. Now, what is the classification depending on type of complex? You have type 1, type 2 and type 3 complex. Type 1 is a strong complex and it includes ferric carboxymaltose, FCM, and iron isomaltoside I am going to talk about. And then type 2 complex, moderately strong iron sucrose that we have used, And somehow we have switched over to FCM, and many of us are not using, except for GPs. Why do you think GPs are using iron sucrose? Even now, you give them free of charge I3, which I am going to talk about. Even then they will give iron sucrose, because patient has to come at least 4 to 5 times for the total dose that she has to take, or even 7 times. So every time she can be charged, okay? That is the advantage of iron sucrose for GPs. Now, mild to moderate iron deficiency anemia. What do I mean? Hemoglobin more than 10, but less than 12. Ferritin less than 100 nanogram per milliliter, transferrin saturation less than 20%, and the total dose calculated is around 1,300 to 1,800. Start oral iron, 1,000 milligram per day, give for 4 to 6 weeks. If the hemoglobin increases by 2 grams or more per deciliter in 4 to 6 weeks' time, continue oral iron. There is no need of unnecessarily giving her intramuscular or intravenous iron. I am not here to push only intravenous iron. Now, hemoglobin does not rise by 2 grams per deciliter in 2 weeks' time. You will give intravenous iron to cover the total dose deficiency. This is very important. Why you are going to give intravenous is because you want to cover the total dose deficiency. Unless the iron stores are depleted, your hemoglobin will not fall. So the very fact that hemoglobin has fallen and she has come with less hemoglobin than what it should be for Indian standard, you know that she has deficiency of iron stores. Give her iron sucrose 7 to 9 doses of 200 milligram, 100 to 200 milligram. FCM at least 2 doses, maximum up to 1000 milligram, and iron isomaltoside you can give up to 1500 milligram. Now remember this, at a time you can give up to 1500 milligram the iron isomaltoside. Now, severe iron deficiency, almost the same picture, but the total dose calculated is more, and it's the same thing that you can give for 4 to 6 weeks, and if the hemoglobin rises by 2 or more grams percent, fine, monitor her. Now, we have this iron, dextran, ferric gluconate, etc. What is a carbohydrate shell? For iron dextran, it is low molecular weight dextran. Ferric gluconate, obviously gluconate, sucrose, FCM, carboxymaltose, and this iron I3 isomaltoside, which I am going to talk about, is isomaltoside. Okay? What is the importance of this carbohydrate shell in parental iron? Every parental iron is complex with carbohydrate moiety, which holds the iron till the iron complex reaches the liver and spleen. Stronger the complex, safer is the parental iron, because it will release less labile iron, free iron. Now, what are these labile irons and how are they harmful? Labile irons are free ions released from iron complex after administration. Since there are free ions, they are responsible for effects like hypotension during intravenous infusion, hypersensitivity reaction, oxidative stress, and cytotoxicity, etc. So this labile iron potential is very less with iron isomaltoside I3. So why iron isomaltoside has low labile iron potential? It is very complex, which is there, it's tightly bound in a matrix structure, and this enables controlled and slow release of iron to iron binding protein, avoiding potential toxicity from release of labile iron. This is what happens compared to iron sucrose, one on the left side, and compared to ferric carboxymaltose, FCM, the one in the center, I3, has the lowest labile iron possible when it is given. Now, when you compare this I3 intravenous iron isomaltoside with other intravenous irons, what is the best thing that you look at is that maximum single dose for iron sucrose is 200 milligram at a time when you are giving intravenous. For FCM it is 1000 milligram, whereas here you can give up to 1500 milligram at a time. Iron isomaltoside is not the only intravenous iron preparation with no upper limit of intravenous iron administration, but what we get written is maximum dose that can be given in a single visit is 1500 milligram. Don't ever go beyond that, even if she requires more than that. What is iron isomaltoside? It's a third generation intravenous iron compound introduced in Europe in 2010. The DCGI approval was given in 2013 August, and it is approved by US FDA in January 2020. How many of you are using this I3 here in Solapur? No hand raised. By the way, it is available in Maharashtra. It is available in many states of our country, though not all, but in Maharashtra it is available. What is the mechanism of action of I3? It's a parental iron isomaltoside absorbed by reticuloendothelial cells of liver and spleen. Splitting of iron complex occurs by reticuloendothelial cells in liver. Iron binds to protein and forms ferritin, and this replenishes the iron stores. Very, very simple to remember for some of the younger generation gynecologists that are present here. Now, whenever you talk about something new molecule, you would always like to know what is new about it. Have you compared it with whatever we have been using all these years? So yes, there is a comparison between I3 and iron sucrose and comparison between I3 and FCM, ferric carboxy maltose. Let's see, what is it? In blood volume, 2018, single infusion of iron versus multiple infusions of iron sucrose. So that is the biggest advantage. You require one visit for I3, whereas you require multiple visits, almost up to 5 to 9 for iron sucrose. Single infusion isomaltoside versus multiple infusions of iron sucrose. What is the hemoglobin increase from baseline? After 2 weeks, about 1.48 for I3, and it was 1.19 for iron sucrose. And the proportion of responders with hemoglobin increase more than 2 grams per deciliter, 32% for I3, it was 20.8% for iron sucrose. Now, percentage of patients with increase in hemoglobin more than 2 grams per deciliter for I3, 68.5%, it was 51.6 for iron sucrose. Number of administration, we all know that. Median time for hemoglobin increase, now this is again equally important, 26 days, whereas it was 37 days for iron sucrose. So what is the superiority of I3? It's a latest generation IV. Iron isomaltoside has less potential of labile iron, does not require test dose unlike iron sucrose. Very important, iron sucrose don't give without test dose, please. I have seen patient dying in teaching hospital. Iron sucrose can be given as a maximum 200 milligram, not more than 3 times a week, and dose must be at least 24 hours apart, iron sucrose. While I3 can be given 20 milligram per kg or more than 1000 milligram in a single visit, and it gives you faster and higher hemoglobin rise with I3 compared to iron sucrose. Now, as I told you, they compared I3 with FCM, the ferric carboxy maltose, which we are using now in our practice. There is high risk of hypophosphatemia with ferric carboxymaltose came in bone January 2022. The FCM given in one sitting causes raised fibroblast growth factor, which leads to reduced phosphorus level, which leads to reduced vitamin D level, reduced calcium absorption leading to, and all these things will lead to hypophosphatemia. Okay? This came in bone, that's a journal, 2022. JAMA gave this in 2020, and there is a 10 times higher incidence of hypophosphatemia with FCM. In Mumbai, one of my friends from KEM hospital had a patient who got hypophosphatemia without anybody realizing it, till we went to the physician who asked for these levels and said that this could be the reason. Okay? So, 10 times, as you can see, 75% and 73% for FCM, whereas iron isomaltoside was around 7 to 8%. There is a 10 times difference, more chances of hypophosphatemia with FCM. Not only that, people started talking about money involved in this treatment. Obviously, in India, country like ours, we always think from the point of view of patients' pockets. One ampule of I3 costs how much? 1,700? 500 milligrams. It is double for FCM. Okay? Now, when you calculate total dose of sucrose that has to be given, it comes to half the amount, actually, if you really ask me. But the patient has to go so many times to the doctor, going, coming, time, all those things. If you see, everything comes to the same thing as I3. So there is a nice paper which I read. It came in Journal of Economics. We don't read economics. It comes only in G20. We don't read all such things. No, Pankaj is a different person altogether. I have a respect for that. But this came in 2020, and a patient level cost effectiveness analysis of I3 versus ferric carboxymaltose was carried out. And in UK, again, this is not from India, this is UK. What they found, the first table is of FCM, this, and this is of isomaltoside. And they tried to find out what was the change from baseline hemoglobin. It was slightly better with I3. Proportional responding also was better by 10%. Hemoglobin after treatment was slightly more with I3. Iron infusions required obviously less with I3. The total cost of infusions in pounds, look at it, 637 for FCM, whereas it was 458 for I3. And the cost per responder in pounds was 910 versus 579. If you convert it into rupees, I think it is definitely significant, especially in country like ours, where in our private practice, no patient asks how much does it cost. But for a poor patient who comes to teaching hospital, if you have to ask her to get it from outside, obviously it does matter. Okay? It does matter. So, again, the cost-wise, it is found to be slightly better. So, what was the conclusion of this paper? Analysis showed that using iron isomaltoside rather than FCM patient with IDA would reduce the number of iron infusions required to correct iron deficiency, thereby reducing the costs associated with IDA treatment and simultaneously increasing the proportion of patients with IDA experiencing a clinically meaningful hematological response. Okay? Right. How is it superior to FCM? I3 is tightly bound and shows very low concentration of free iron, and free iron concentration in FCM is significantly higher. We told about hypophosphatemia. Single iron deficiency correction in single visit with I3. Now, is it that this I3 is used only in obstetrics and gynecology? No. It is used in chronic kidney disease, inflammatory bowel, and gastroenterology, oncology, cardiology, and perioperative care. So, I3 in IDA during pregnancy, obviously it's a category B drug like iron sucrose and FCM. The higher doses of 1500 milligram is safe during pregnancy. The risk of serious and severe hypersensitivity reactions was lower with I3 relative to FCM and iron sucrose both. International Journal of Transfusion Medicine, April 2017, 213 pregnant women from the beginning of second trimester till a few days before delivery, each received a single administration of 1000 to 1500 milligram intravenous I3. They were observed for adverse effect. What was the conclusion of this paper? That these results support the convenience, safety, efficacy of a single high dose up to 1500 milligram infusion of intravenous iron isomaltoside for iron deficiency anemia. Negligible patients reported mild adverse drug reaction. What about postpartum period? If you ask me, I retired from KEM, but before that, we used to give all patients 1000 milligram of intravenous iron if the hemoglobin done 24 hours after delivery was less than 10 grams. Very simple. Less than 10 grams, 24 hours after delivery, give 1000 milligram intravenous iron. Let me tell you, once this patient goes home, she will not come back to you unless her baby has some problem. She will not come back to you for her problems. And if her stores are reduced, she will always feel low all throughout after delivery. One shot of 1000 milligram is going to help this. And let me tell you, especially in teaching hospitals, we have been trying to request the government of local states to make these products available, injectable iron, available free of cost, so that it can be given to so many patients who are delivering in municipal corporation and government hospitals. Postpartum period, Journal of Maternal Fetal Neonatal Medicine, 2019. What was the conclusion of postpartum fatigue? Single dose I3 is associated with statistically significant and clinically relevant reduction in aggregated physical fatigue within 12 weeks after delivery. Then maternal milk and I3. Something very interesting, I feel. We just finished a week of promotion of breastfeeding in August. International Journal of Gynecology and Op 2015 that iron I3 is increasing iron content in maternal milk. What was the conclusion of this paper? That the treatment with high dose iron isomaltoside, at least 1000 milligram, resulted 2 times higher iron content in maternal milk. These are all the papers available for anyone to go and look at. Then Fox Sang 2017 in postpartum anemia. The study shows intravenous iron could be an attractive alternative to RBC transfusion in severe postpartum anemia. Now, what about dose calculation? I told you earlier on 2.4. But if the hemoglobin is more than 10 but less than 12, patient's body weight less than 50 kg, give 500 milligram intravenous. If patient's body weight is 50 to 70,000, more than 70,500. But if her hemoglobin is less than 10, which is the situation in our country most of the time, and if she is less than 50 kg body weight, give 500, but if between 50 to 70, 1500 milligram and more than 72,000 milligram of intravenous iron. Total dose per week should not exceed 20 milligram of iron per kg body weight. Please remember this. Per week, no more than 20 kg of I3. Hemoglobin level should be reassessed no earlier than 4 weeks post final I3. Repeat hemoglobin 4 weeks after the dose of I3. If the iron needs exceed 20 milligram of iron per kg body weight, the dose must be split into two. Suppose it comes to 1800 milligram, more than 1500. Then you split into two, like 900, 900. And split into two administration with an interval of at least 1 week. Don't give alternate day or something. Once you give 900 milligram, wait for 1 week, then again give 900 milligram. Administration rate for intravenous infusion, again equally important. I3 should be infused undiluted or diluted in 0.9% sodium chloride. Now, how much? For stability reasons, I3 should not be diluted to concentrations less than 1 milligram of iron per milliliter. Less than 1 milligram of iron per milliliter, and never diluted in more than 500 cc. Never. Around 200 cc is fair enough if you want to give it in normal saline. Blood transfusion, I don't think I am going to say anything about it. All of you know the indications, etc. We know the risks of blood transfusion. Try and avoid that. So if you have pregnancy less than 30, iron deficiency anemia, give oral iron. If there is intolerance or non-compliance, you can give either intramuscular or intravenous. Folic acid deficiency, obviously oral folate. Pregnancy between 30 to 36, IDA, parental iron straightway, intramuscular or intravenous, whatever you believe in. Folic acid deficiency, oral folate therapy, and if the pregnancy is more than 36 weeks, if she has iron deficiency anemia, depending on what is the hemoglobin, you may give her blood transfusion. To summarize what I told you on Sunday morning, ladies and gentlemen, intravenous use in women of reproductive age has increased rapidly. I3 is the only intravenous iron that can be given as 1000 milligram and above in a single visit up to 1500 milligram. Faster and higher hemoglobin rise with I3 as compared to iron sucrose and FCM. No test dose is required. Possibility of providing full iron repletion in a single infusion. 1 dose iron repletion. In clinical and observational studies, no acute anaphylactic or delayed allergic reactions were found, and I3 is safe, effective, and convenient, and a low immunogenic potential, low potential to release labile iron does not appear to be associated with clinically significant hypophosphatemia, and there is less overall treatment. Thank you very much for your patient hearing. And questions, please. Pankaj.
Thank you very much, sir. Any questions?
Please use mic if you don't mind.
Why oral iron should be stopped before giving intravenous?
Toxic
What is the
therapy.
reason?
It's simple. You are giving double dose. You are giving oral iron which gets absorbed and goes into the blood, and on top of it you are giving either intramuscular or intravenous iron. So try and avoid this. This has been found. This has occurred.
Exactly.
And that is why all this advice. Very simple. 24 hours before any parental iron, stop oral iron.
And when to start it again? If you want to start, that we feel that the patient may not continue with the same iron or HB levels.
Okay.
And if you want to start oral iron tablets, when we can start?
Any time after first trimester. I never give any iron in first trimester.
After injectable
Around
irons.
14 weeks onwards, you can give oral iron. Try and
1 week
No,
after that.
after injectable irons.
1 week I said, I had already said 1 week. You give last dose of whatever preparation you have given, parenteral, wait for 1 week to restart oral iron. Okay? I hope.
So is it mandatory to take written informed consent before giving iron injection?
No. Not for intravenous iron. We don't take any consent, please. Like we don't take consent for any intravenous antibiotics, etc. So it's a therapy. So therapeutic injections, you don't require consent. Any other new question? I like this question because this was never asked about consent.
Duration it should be given. Duration. In within how many, 20 minutes should we finish?
Sorry?
Duration of intravenous infusion.
Time.
Time.
So you started.
Huh.
Okay. When you give undiluted, I told you there are two ways you can give. Either undiluted or dilute with normal saline. Whenever you use any iron preparation undiluted, take at least 15 minutes. You withdraw the blood and inject slowly. Again withdraw the blood, inject slowly. Withdraw the blood, inject slowly. Okay? Because if you have very little amount of fluid, you can't wait for 15 minutes. You will finish it up in 5 minutes. So the best way you can dilute is blood of the mother herself. Okay? Very simple. Now, if you are giving 0.9% sodium chloride, 200 cc, give at the rate of 15 drops a minute, give it for 2 to 3 hours. There is no hurry, either for you or for the patient, because with the experience that we had of iron sucrose, with the experience that we had of FCM, we feel that there is no need to infuse unnecessarily diluted iron. Okay? So take your own time, minimum 2 to 3 hours, and always monitor the patient. The deaths, we have gone into the details of deaths because of intravenous parenteral iron. Majority of the times, it is the non-monitoring of the patient that has led to such adverse effects of maternal mortality. Two of the big companies that were manufacturing these drugs were involved. Big companies, I don't want to name them. And the whole thing came up, and the whole detail they went into all these deaths, and they found that the patient, they started the IV and left. Like our residents, even in KEM hospital, Sion hospital, where I worked for 33 years, the residents, you can't expect that resident to sit with one patient. She has to look after so many other patients. This is what leads to, sometimes some patients' relatives are smart. They want to finish it off fast, and they increase the rate. All such things happen.
Then how much the patient should remain for observation for how long? Undiluted. You have just pushed it.
If you are given undiluted, normally whenever you give any intravenous thing, though government has not asked for any test dose, see that you have everything available for anaphylactic shock. Even if they claim, both FCM as well as I3, that there is no anaphylactic shock, always keep the anaphylactic shock treatment kit ready, one thing. And once you are given, you have taken out the needle, just wait for half an hour or so, let the patient remain there. Ask her, how are you feeling? Are you feeling giddy, vomiting, anything of that sort? Nothing, and she can have a cup of tea, biscuit, and go home. Thank you. Thank you very much.
Thank you very much, sir, for new insights. Thank you very much for
Now I request chairpersons to felicitate our speakers. Dr. Agrawal, madam. Dr. P.K. Shah. Now I request our president to felicitate the chairpersons. We will move on to inauguration shortly.
Good morning all. I take this opportunity to invite our guest for inauguration, Dr. Pankaj Desai sir, Dr. P.K. Shah sir, Dr. Pushpa Agrawal madam, Dr. Bangal sir, Dr. Kumthekar sir to please take their seats on the dais. I also invite President SOGS Virkar sir, Meena Gunjotikar, Dr. Khare to be on the dais. एक चेअर अजून इथे कॉर्नरला. I welcome you all for the inauguration of today's CME. Lighting of lamp is not only an auspicious, but it is also a representation of triumph over knowledge and ignorance. I request all the dignitaries to please come forward for lamp lighting ceremony.
गुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं गुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्यो.
Thank you. I now call upon Dr. Virkar sir, President SOGS, to express his views about today's CME. He is a person who believes action speaks more rather than words. To you, sir.
Good morning all. Respected dignitaries on the dais, seniors, teachers and dear colleagues. As you know, the theme of our CME is Caesarean section. So Caesarean section is a very commonly performed procedure in obstetric practice and usually perceived as a simple and safe alternative to normal labor. But at times, it can be technically difficult with subsequent health hazards to the both mothers and fetus. And it naturally leads to the increased obstetrician's anxiety and stress. The key to avoid probable problems and obstetrician's headache is the anticipation and meticulous planning. So the anticipating and preparing potential difficulties, so the proper mobilization of resources and well-planned incisions and other should go a long way to prevent the complications. So the golden rules to summarize are anticipation, preparedness, staying calm, being gentle, share lessons with peers and debriefing. Thank you.
Thank you, sir. Teachers' Day was recently celebrated everywhere. With these great teachers as guests today, we on behalf of SOGS would like to felicitate our gurus today. It is rightly said, better than 1,000 days of diligent study is one day with a great teacher. Today, I am immensely happy as we take this opportunity on behalf of SOGS to express our love and gratitude towards our teachers. Their devotion, hard work, and eternal positivity has allowed us to what we are today. We all have witnessed their passion for teaching, which is truly commendable. We are immensely honored by your gracious presence today. As a token of gratitude, we would like to felicitate our teachers. I request Dr. Pankaj Desai, sir, to felicitate Dr. Sardesai, madam. Sir, Sir. Dr. Sardesai, madam, is a teacher par excellence. She derives immense pleasure in teaching and conducts classes and clinics for PG students with great enthusiasm. I also request Dr. Pankaj Desai, sir, to felicitate Dr. Munot, madam.
Sir, I bring.
Munot, madam, she is a warm person, a dedicated teacher, and a motherly figure for our society. I now request Dr. P.K. Shah, sir, to please felicitate Dr. Tirankar, madam. Is she here? She was there. Tirankar, madam, please. She is a devoted teacher, a true visionary, and her passion for teaching is truly commendable. Thank you, sir. I now request Dr. Bangal, sir, to please felicitate Dr. Pradeep Patil, sir. He is a young, talented, and a dedicated teacher who always inspires and supports his students. We thank you, our great teachers, for gracing this occasion by their presence. Thank you, all the dignitaries. You can go now. Yes.
Now we move upon to next session. We will start our next session. For that I call chairpersons Dr. Bahubali Doshi sir and Dr. Madhura Virkar. Dr. Bahubali Doshi sir, very senior practicing gynecologist and obstetricians and 40 years, ART consultant in Navjivan Infertility Center. Dr. Madhura Virkar, consultant gynecologist obstetrician since 20 years at Virkar Nursing Home. Over to you, chairpersons.
दादा हॅलो HDMI आहे का हे माईक बंद
Good morning, friends. It's indeed really a great pleasure, especially, personally for me, to introduce Dr. Pankaj Desai. I am going to split that into two parts. One is a formal and one is an informal. He is a consultant OBGYN specialist at Janani Maternity Hospital, Vadodara, former Dean, Students Association, Professor and Head of the Unit of Medical College, Vadodara, Gold medals awarded in OBGYN, 61 orations to his credit, innumerable guest lectures, moderator, panelist, and similar academic honors, 107 publications, 13 books authored, contributions of chapters in different textbooks, and so many. The informal part is, every day he can give one pearl of wisdom. Just today morning he said, you should always walk on the right side in life. See, actually, Vadodara is known for the Maharashtrians for one thing, that is Sayajirao Gaikwad. And to all the gynecologists and practitioners for Dr. Pankaj Desai. He has a fantastic sense of humor. I am his Facebook friend, and on many occasions we also exchange few things on Facebook, even on WhatsApp. His politeness or humbleness is just evident when he escorted the teachers today. See, he has a phenomenal memory that he remembered the date of Shirodkar oration which he delivered here in 2003. He is a friend to many and philosophers to all. I request Dr. Pankaj sir to deliver his speech.
कमी नका करू हां असं जाऊ दे थँक्यू हे नको आहे मला. I will start as usual with a prayer. As wind carries our prayers for earth and all life, may respect and love light our way. May our hearts be filled with compassion for others and ourselves. May peace increase on earth, and may it begin with me. Honorable President of Solapur Society, and through him all the leaders of this organization, Honorable Secretary Dr. Meena ma'am, and through her all the incoming leaders of this organization, Honorable Dr. Bahubali sir, and through him all members of this organization. And by protocol, this is a constituent organization of FOXY. So, Honorable Past President of FOXY, Dr. P.K. Shah, and friends. This lecture will not end now after 40 minutes, 30 minutes. You can contact me 24/7, and there are at least 4 people in Solapur who continuously are in touch with me, not only related to sweet nothings, but also about their personal problems in their practice and so many other things. So I will be bringing this again and again during the presentation, and so you can copy it down, and my website is there. You can contact me. I will 100% reply. 100%, but when I will reply, I don't know, but I will 100% reply. That is a teacher's promise. I was specifically asked by Dr. Virkar sir that, sir, we want nuances in LSCS. And he modified it, and I took it from there. Nuances in LSCS sailing through challenges. These nuances will happen only once in life. What will happen every day have already been taught to us for years together and decades together in medical college. For that, you don't come to a CME. In CME, you come to have additional package, extra package. When one of my cars insurance was to be renewed last week, my wife told me that please see that what extra they are giving, because routine we have already insured, so what extra? And this is not the main lecture, but I'll take 5 to 6 slides for something which is bugging many practitioners, and therefore just sensitizing you to that as a teacher, and that is the challenge of invasive placenta, which is a nuance for us now comparatively. In my entire residency and in my entire assistant professorship and professorship, I have seen hardly one case. But now the situation is completely different because increased incidence of Caesarean section. Whatever be the reason, it's okay. We don't want to criticize, and we don't want to become judgmental. Fine, it is saving millions of lives, and anything good. Bahubali sir will bear with me that when we were young, we had a song in film Kajal, "Achho ko bura sabit karna duniya ki purani aadat hai." So let us not criticize Caesarean section and join that bandwagon. But there is a good news. And what is that good news? That ultrasonography is sensitive enough and specific enough for the diagnosis of placenta accreta. If you are not doing all ultrasounds yourself, then whenever you send one for an opinion, which I do, or if you are doing all, I send only one for a 20-week scan, so that I don't miss any of the malformations and whatever we do at 20 weeks. Specifically ask for, and you can look for it also. Teachers like Dr. P.K. Shah have taught us, and Dr. M. Rawal, his teacher, about ultrasound. And This is what we have to see. This gap. If it is there, relax. Specifically, your eyes will see what your mind knows. The interface between the bladder and the uterus is usually fairly thick and clearly identified. If you find that there are gaps like this, if this is, then please ask for an opinion or label it as invasive placenta, and you know how dangerous it is, and still not be afraid of it. Medical legal people have made us extremely fearful for one case which might happen in the entire life. We shudder 24/7. So don't be afraid, but handle it professionally. This is last week's ultrasound in my hospital. This is a normal finding. Don't start jumping just because you see a vascularity. You can see here, actually it is the cervix, and here is the lower segment. This vascularity is very much above, and this is a normal finding in early pregnancy. It can be there, so don't start jumping, also discern between the two. I'll finish it here and then come to this main lecture. Be aware of it. Specifically look for it or request your sonologist. Specifically now, in cases of previous scissor, please commit or rule out invasive placenta. Bas, that will be enough. Now we come to situations we'll get once in life. They are all true to life situations as happened throughout the world, somewhere or the other. Most of them in India. I will tell you the source also from where they have come. And I will require a microphone, and I might ask you to tell as to how you will handle. Can I get a mic, please? Will you help, please? मी तुम्हाला सांगेल, मध्ये फिरायला लागेल तुम्हाला. Okay. These are not run-of-the-mill cases. No. For that you don't require me to travel. Started yesterday morning at 5 o'clock. My driver picked me up and dropped me at the airport to come here and give a lecture today at 11 o'clock. Run-of-the-mill, everybody knows. But something new, and see this. A 37 years old G3P2 was admitted with 36 weeks gestation, obstetric history, first full-term normal delivery, second LSCS for placenta previa. Are you with me? I am going to ask you questions so that you don't go to sleep. Of course, I will not ask PK Shah or Bahubali sir or Sardesai madam or madam there, because they have taught me. Okay, here we can exchange ideas. She had multiple cardiac surgeries. And was on therapeutic dose of heparin. Taken up for emergency Caesarean section, this time for abruption. Okay? Markedly thinned out ecchymotic and friable scar of previous Caesarean section, repaired in 2 layers, tubal ligation done, anticoagulation treatment was resumed appropriately, and post-operative period was uneventful. Okay, has the soup warmed you enough? Yes, ma'am, we'll ask you. That with beautiful pink colored dress. Yeah? Yeah, we will ask you. Yeah? Mike, तिथे घेऊन जाईल? मॅडमला देईल का? Please. आराम से, keep sitting. This is getting recorded and it will come on YouTube channel next week, and I will give you an SMS also as soon as it comes. Is this fine, ma'am? Yes. Yeah? Okay. After 3 months, she comes to the OPD. She presents with recurrent periodic spotting and bleeding. She was on warfarin, but her coagulation parameters were not much affected. So that is not the cause. That is the easier one, but I would not have brought it here if that was the easy one was acting. Everybody knows. There was no chorionic tissue on ultrasound, because you will start thinking of a molar insult or something. No. Endometrium showed a thin strip. Normal beta HCG. What is happening and what would you have done, ma'am? Please. आपके पास mic है, बैठे बैठे कहिए. She has walked into your OPD. We will take 1 case or 2 cases and finish as soon as the time is over. That is my promise to you. We will not go much. Yes, please. Ma'am, what would you do? Such a case, We did a Caesarean section, TL done, bad scissor, and now she is coming after 3 months with continuous bleeding per vagina. And ultrasound norms, apparently normal. Any ideas what you would have done? We are not there. There we have to decide in your consulting. Would you like to give her some hormones? Yeah? Yes? Somebody said yes. Okay. Okay. Medical management was done. She was put on progesterone along with oral iron therapy. She returned after 6 months postpartum for continuous bleeding PV. On examination, bulky, firm lower uterine mass on clinical examination, felt adjoining the uterus, and on color Doppler, no vascularity. I will show you the picture. This is the mass. Yes. And this is the cervical canal. This is the mass here. Okay? I'm giving you one more picture. Lower dimensions of the heterogeneous mass, it is quite big mass. But there is no vascularity, so don't start jumping about malignancy and this and that. No. It is rare, but something has happened. Okay? Madam, jawab dijiyega. मैं इंतजार कर रहा हूं. As an obstetrician and a teacher, we are very patient people. Okay. A presumptive diagnosis of a poorly healed lower uterine segment with inadequate drainage was made. This is got formed that way. Okay. In view of her multiple comorbidities including hepatitis C, being on interferon, ribavirin, and therapeutic anticoagulation, the patient refusing any operative procedure and further waiting was now dangerous. What is to be done? Madam, what would you have done? Think out of the box. I will come there and pick up the mic and I will request the projectionist to come here and change the slides. तुम्ही येल का इथे कोणी एका प्लीज तुम्ही प्रोजेक्शनचा कंट्रोल घ्या मी माइक मध्ये बोलतो या स्लाइड करेल तुम्ही चेंज या स्लाइड चेंजर देईल हो what do you think it is not difficult काय करणार think out of the box okay no problem I have no reasons to embarrass you दादा चेंज करेल का बसा okay she received monthly administration of intramuscular GnRH analogs 3.75 milligrams for a period of 6 months. Okay, next slide. No, previous next 2 months later she had an acute episode of lower abdominal pain and passage of a large amount of altered blood expulsion from the collection. Okay, are you with me?
Yes.
Yeah? It's a little tough, yes, no problem. I would not have brought it here. Just keep sitting. Can we have the next slide, please? On follow-up, next slide. Her platelet count was 1,02,000. Comfortable. INR 2.3. She was on what? Menstrual bleeding stopped, whatever she called menstrual bleeding or spotting per vagina. And I'm bringing the ultrasound. Wait, what do you expect on the ultrasound picture now with this picture?
Maybe the mass has reduced in...
Yeah, resolving. Can you have the next slide, please? Here you can see, 1 month later, normal appearing endometrial cavity and persistence of a heterogeneous mass, lower segment mass. You can see the endometrial cavity here. Yes. Here. And the mass is there, but seems to have become a little silent. Her normal menstrual periods resumed 2 months after stopping GnRH. And USG picture was this. You can see here. Transvaginal USG 2 months after completion of, notice the absence of lower segment mass. You can see here it is resumed. And normal looking endometrium. Okay? Little thinking out of the box. No surgery was required. And now what is the picture? The patient has now no gynec complaints. 4 years later, after her last Caesarean delivery, post GnRH analog induced amenorrhea stopped constant irritation of the uterine scar adhesions and promoted healing. So think a little out of the box and you'll get a solution. Yeah? This case came to me from US, New York, but this lady, many of us have heard her, Lakshmi Bai, and she had reported this case in a very reputed journal. Here Caesarean section happened long ago. Next case. And see what happened. A 30 years young subject came to the emergency department with acute abdominal pain, nausea and therapy-resistant vomiting for 12 hours. She had a history of Caesarean section performed 2 years earlier. 2 years before she had a Caesarean section. Okay? Shall we go ahead? Ma'am, I am going to target you. Can we go ahead? Yeah? हाँ स्टूडेंट है तो क्या है हम भी स्टूडेंट हैं I was writing down notes in the previous 2 lectures. See, a student is selfish, a teacher is unselfish because the student only collects, teacher collects and gives. Okay, so we will see now. She was afebrile and her physical examination revealed generalized abdominal distension and tenderness with tympanic bowel sounds. Something with the intestines?
Adhesions or something?
Adhesions. Okay, excellent. We will go further. Okay, laboratory investigations were done as usual. WBC count of 9260, hemoglobin 11.9. She had no comorbidity. Clinically, what do you think has happened? You already answered, there are some adhesions. Yeah? Fine. Let us see ahead. They did an imaging. Okay? You will ask for an ultrasound now? Yeah. Okay. USG abdomen pelvis showed free fluid with probably a hydrosalpinx that had undergone a torsion. Should we explore or ask for further investigations? So we directly intervene. They did not directly intervene. They asked for a further, they got an MRI done. A contrast CT, revealed a marked distension of the stomach and small bowel, multiple air fluid levels up to middle proximal ileum, and there was a transition bowel loop with no appreciable cause of organic obstruction. Okay? So you would have gone inside to handle the hydrosalpinx, not calling the surgeon, and then phone calls would have started. So they investigated. Okay, probably a little more experienced gynecologist. Yeah? And you can see here multiple collection of fluids here. Left us wondering that what is happening? How after 3 years of surgery? अब ये सब नहीं होना चाहिए ना. After 3 years, nobody thinks of all this. Exploration, laparoscopy or laparotomy with this finding. You can relax. Ma'am, laparoscopy, laparotomy? Laparotomy? Okay. Unluckily, we didn't follow your suggestion. Considering the previous LSCS, we are giving explanation also. And the probable presence of a single adhesion band, you say, yeah? So stick to what you say, don't worry, most of the times you are right. Despite the hyperdistension of the intestinal loops, a laparoscopic approach was, with possible conversion to open lap surgery, was decided. This is not the picture of that. But this is the usual thing we see so many times. This is my last week's TLH picture, previous Caesarean section. And this is what we had expected. That ऐसा होगा, पर ऐसा नहीं था. ऐसा नहीं था. On laparoscopic exploration, the pelvic cavity and the uterus and the tubes were normal. After the initial exploration, we identified a mid-ileal gangrene. Okay? This happened to my niece, my cousin, first cousin's daughter. Okay. The mid-ileal gangrene was caused by pelvic adhesions following previous Caesarean section, with remarkable distension of small bowel loops. The adhesions were to the previous abdominal scar. So anything can stick, yeah? No problem. The ileal loop responsible for the obstruction was ischemic and necrotic, and adequate laparoscopic adhesiolysis and laparoscopic resection followed by anastomosis was performed, and postoperatively she was fine. Our patient had an uncomplicated postoperative course and was discharged on postoperative day 5 in good health. A small query remained in my mind. Was this preventable? Bahubali sir, what do you think? Is this really preventable? If no, why not? And if yes, why? Sardesai madam? 3 years after, yes. Yes. So nothing is to be done extra. Just this can happen, be prepared for it. Yeah? Okay. But it can happen late after 3 years. So once this case was presented in Indore, in Guwahati and Patna, and about 2 months before I got an email from Patna, one of the audience members. She emailed me that, sir, thanks to this case, we got a case now after 3.5 years, and because of this we were aware of it and we could easily manage her, and we were not ruffled. Okay, they were not ruffled. So therefore you come to such CMEs to learn new things, maybe rare, it's okay. Now one more unexpected thing. A 25-year-old G2P1 complained of cyclical oozing of blood from her Caesarean section scar for 3 months during menses. Okay, yeah, I know. If it was so easy, I would not have brought it here. She had history of LSCS done 9 months back, with no past history of any chronic ailment, including tuberculosis. On abdominal examination, 2 pinpoint openings were seen at the scar site. 2 pinpoint openings, not the full scar. Okay. On ultrasonography and CT scan, there was an evidence of fluid collection anterior to the uterus, which communicated with the skin by 2 linear tracts of size 2.6 by this, and another also 2.4 by 9 by 0.36. I'll show you actually the collection and the scar. Please keep watching here, and here. Okay, we go further. Fluid was seen coming through the fistulous opening on the skin, and the other end of the opening was seen at the level of isthmus. So hysteroscopy was done, and hysteroscopy showed these openings in communication with the abdomen. Anyone would like to tell what has happened? Fistula. Okay, enterocutaneous fistula. Okay, any other input? And sir, why must have that occurred? Because we do thousands of Caesarean section. Madam has analyzed 1,700 in her data from January to August. So here, sitting here, if there are 50 people sitting here, 8,500 from January to August. 85,000 Caesarean sections. So many. And why it doesn't happen regularly, and why must have it happened here? Any ideas? Anyone can give an input. What do you feel about this? Suture material did not get absorbed, even though Vicryl was used. It can happen. Fine, thank you, madam. Uterus was densely adherent to the anterior abdominal. I will show you the laparoscopic picture also. Now what? See this. This is the abdominal wall. This is the adhesion. This is the uterus. We all know this. What should we do? Anyone? Dissect it free, that's all, and finish it up. Adhesiolisis, that's all. And close both the ends of the fistula. So let us see what they did. Adhesiolisis was done with harmonic and scissors, that's all of us do. The opening of the tracts in the uterus was visualized by passing dilators. Through the fistulas opening from the skin, and right up to the skin it was excised. The abdominal LSCA scar with fistulous tract, that entire thing was excised. Not only that closing of the openings, because the problem is deep inside. It is not those 2 points is where you see the fluid. Poor healing is always around. We know this. Okay. The abdominal LSCA scar with fistulous tract were excised and sent for histopathology examination. This was the picture. You can see here from the abdomen, skin, and this going inside, and this whole thing was excised and resutured. Remaining defect was resutured. Was it good to send to histopathology? Yeah? You expect something? Arey wah! Salute Solapur. Therefore, Baroda adopted your name for even our Chivda, Solapuri Chivda. Okay, Baroda is famous for that. Histopathology of the sinus tract was suggestive of tuberculosis. Patient was started on anti-tuberculous treatment and post-operative wound healed without any complications. Credits to, I have his permission to present, I rang him up. Dr. N. Shah from Mumbai, from Vardhan Multi-Speciality Hospital, and had some additional features also asked him on phone. The next was the price you pay to be a senior. And what was it? She was in her third pregnancy with previous 2 LSCs. This patient, which we are going to discuss. The obstetrician was sure that she will go in for one more pregnancy as the gender of the child were not of the liking of hers as well as her family. Fine. Not discussing all those. Daya baini, dai vato, leave it outside. She was told, go to a senior doctor next time, don't come to us. I will say, go to Sardesai madam or Bahubali sir, don't come to us. And so she came to me. I studied the operative notes that was also given along with it, and quite a detailed notes. It stated that there were dense adhesions between the lower segment and the bladder, and only with great difficulty could they access the lower segment. Already, in the previous Caesar, one Caesar only, her healing system was such that it overreacted. Okay, as we saw this morning, regarding the free iron which gets released, in some it was the labile iron. The explanation was given was that this is immunological response. So how it responds, we don't know. But in her, it responded in this way. Less how many previous Caesarean sections, even previous 2 Caesarean sections, nowadays we take them up for TLH. Okay, we see adhesions, but this was too much. They were not able to access the pelvis. So what choices I had before me, I'll discuss with you and then come to another alternative. I discussed with my wife and we decided that either we do a classical Caesarean section and a concurrent sterilization, or try dissecting the bladder patiently and be prepared for both hemorrhage and bladder injury. Okay. You agree with me? These were the choices which I thought at that moment. But usually your best thoughts come when you are under a shower, and that is where, sir, you rang me up to this morning, or when you are in the gym. There is science behind it, that your synapses which are firing at the same frequency, they break in gym when you are exercising. And therefore, new ideas come in. Madam, you are a practitioner of yoga, you teach yoga, you know this. The new synapses form and therefore new ideas come. And I got this idea while I was in the gym, and I thought, why not do a cystoinflation? Normally you want the bladder to drain. Nowadays we don't catheterize. For last 25 years we don't catheterize previous cesareans, even any cesarean section. But here you catheterize it, distend the bladder with 200 ml of normal saline, tie up the catheter so that you can see the enemy. Okay, this is its extent. This is what I thought. Do you agree? Will it help me identifying the bladder? Sir? Yeah? Is this a good decision? I am entering, that what was the word used? A surgical strike? Okay, वो जो रात को ही होती है. Okay, this is what I did, discussed it with the team, and I sought support from data. My thinking, your thinking doesn't matter. I want data. Now, Hans Rosling in his book, Factfulness tells, one of the finest books I have ever read, that in case of doubt, fall back upon data. What does data say? Not because I said so. Who am I? Look at the data. And I searched for the data. Thankfully, she was not yet at the point of cesarean section. I got enough time to do research. And I found a good reference. And that reference was just 2020. They conducted a prospective randomized controls trial to find out whether improved identification of bladder margins by sister inflation could decrease bladder injury rate and blood loss without causing urological complications. Okay, let us see what they found. Because madam was giving us data regarding the or preload and co-load. I was looking at it very intently, madam. And when Dr. Pikesha was giving us data regarding iron increase and all, I was looking at very intently. So we looked at the data very intently, and being a teacher in medical college, we are used to seeing data and analyzing data. This study included 214 healthy women with previous operative deliveries undergoing elective cesarean section and found to have dense pelvic adhesions. In this study, sister inflation was very effective to significantly reduce bladder injury rate and blood loss. That bladder apna dost hai. Don't be afraid of it. We did it following this data, and I could dissect through. Of course, cesarean section, Dr. Pikesha being in government all throughout life will tell that you should not do a concurrent tube ligation. We handled it in our way. But then important is, yes, sister inflation can help you in certain very important situations. Will I exactly identify where the bladder is? It will come in the way. No, bladder is a very kind wife. It shifts. If you tell shift, it will shift. It is not a girlfriend who will fight back. Okay, endometriosis is like a girlfriend. It will fight back. It will bleed. Bladder is, it is soft. It shifts. Okay. The last case. Sir, do I have the time for the last case? Yeah? Okay. I have gone to 33 minutes. Last case. Okay. Mrs. S, aged 34 years, G2 P1 with amenorrhea 38 weeks. She had history of previous cesarean section for non-progressive labor. She carried no papers of previous obstetric performance. कोई कागज नहीं है साहब. क्या करोगे आप? Give her lectures, break your head, nothing. Okay, chalo. On examination review, she was found to be fit for vaginal trial, so she was admitted for induction of labor. All other prerequisites we will not go into details. Just on the day prior to the planned delivery, in fact at night, she came to labor room with something coming out per urethra since 4 to 5 hours and severe pain and difficulty in urination. What it must be? Any idea? You get this phone call. Thankfully, I live in the same premise. So you get on the intercom, the nurse tells, Madam, to my wife, we are both gynecologists, Madam, पेशाबची जागावरून काहीतरी येते बाहेर आणि फार दुखते असं म्हणते. What do you think? Bladder prolapse? Huh? Loudly. Calculi. Okay, let us see. Pelvic examination revealed closed and uneffaced cervix. But a bag of membranes was bulging through the urethra, which could be reduced by pushing it into the urethra or by keeping the patient in Trendelenburg position. I will show you the photograph. Gappe nahi marta mein, no fairy tale. You can see it here. Case happens once in life, but once we are aware of it, I am not making you afraid of it. Fearlessness is in my DNA. Never afraid of anything. Here it comes, except my wife. But then, and that also out of love. But then, ऐसा बोलना पड़ता है ना sir? Okay. This is the picture. Don't be afraid, but you are aware कि हाँ एक किसी को हुआ था ऐसा. Okay. What has happened? Anyone would like to tell me what has happened? Rupture uterus? Okay, let us see what has happened. Sonography showed a singleton pregnancy of 37 weeks gestation with adequate liquor. कोई बात नहीं, no problem. We go ahead. A fistula was indeed noticed between the anterior wall of lower uterine segment and the posterior wall of the bladder. That must be a weak area. We identified ultrasound early days. I remember even Dr. M.Y. Rawal telling us, no, lower segment, there are windows. One of those windows, you should not be afraid if you see windows. Okay, on ultrasound, on lower segment. This is a normal finding. But one of that weak point, probably a bag of water was noted to be protruding into the bladder. From there. Okay. How to handle? Anyone would like to tell me how to handle? Madam, don't be worried for a headache. There, madam. Don't be worried for headache. It proves that you have a head. So many times I have to do like this. Hai kya? Hai kya? What do you think? क्या करेंगे आप? आपके क्लिनिक में ही हो गया. क्या करेंगे आप? रात को होता है ये सब. दूसरे दिन पोस्ट किया है, सब अगली रात को ही होता है. क्यों पता नहीं. ये जादू सब क्यों होता है ऐसा? पता नहीं. अगली रात को ही होता है. अगली रात को पेशेंट भाग जाती है. अगली रात को ये ब्लैडर चला आता है. बैग ऑफ वाटर चला आता है. What did you do? You have a wonderful teacher next to you. You will call her.
Sir, open emergency.
Open it up.
Yes, sir.
Open it. Okay. Fine. Classical Caesarean opened up. Classical Caesarean section was done. You can create a controversy, no problem. With sterilization, with repair of vesico-uterine fistula at the same sitting. At the same sitting. Intraoperatively after the delivery of the fetus and the placenta, a 0.2 centimeters wide vesico-uterine fistula connecting the dome of the bladder to the lower uterine segment was noted. कभी एक बार होगा जिंदगी में, पर आपको याद करा के जाएगा. And it will get discussed in the next clinical meeting somewhere and someone will be benefited. The entire fistulous tract was dissected open, separated, and both the openings were repaired. As was the thinking at that time, omentum was tucked in to cover the raw area, continuous bladder drainage for 21 days, and she was relieved of the problem. This case came to us from Jaipur, and this is how it was handled. So friends, Caesarean section can leave long shadows. You have seen after years. And that is where you have to be a very efficient obstetrician and an efficient manager, very alert of what is happening, very in full command of what is happening, well informed, well read, and well informed by attending sessions like this. Then your dedication and commitment will 100% make you feel, and even the patient will tell, well handled. Few days before, got a phone call from one of my juniors. Sir, the patient we did a TLH yesterday was talking with her husband and just gone. Embolus emotion, yes. But then the way we rushed down and the way the team worked, the patient's relatives had tears in their eyes because when I left, I explained as a senior that what has happened. They bowed down to the team. We knew she died, sir. At the moment when she was talking with me, she died. We know. But the way you made an effort, and that is the time, people like me will go out and jump like this, well handled. For that you have to be well informed, well read, and then you can relax to say this. Let our selfless service be our prayers and our meditation. The best way to honor our lives is through serving humanity. There is no better way to honor our lives. No other honors matter. Thank you, ladies and gentlemen. Thank you so much.
Thank you very much, sir, for your excellent, enlightening speech. This interactive session was really wonderful.
Thank you.
Though Caesarean section is done very routinely, one has to face these type of problems at least once in their lifetime. Your speech was very informative with lot of take-home messages. And you have rightly said, sir, that the dedication, commitment and thinking out of the box can reduce the complications like this. Thank you very much, sir.
This was just a drop in the ocean. Pankaj Bhai has literally an ocean of such examples or illustrations. Next presidents should invite him for 1 week and not just for one lecture.
My wife will divorce me, sir. 15 years, retired.
Any queries or questions?
You can email me. You can see on my YouTube channel, there are connections there and you can learn from there. More than 50,000 people have seen that channel. And I message you as soon as this person sends me the recording, and this portion I will. And I am attracted to your this point also. I will include your session or your test and including in Dehradun 15 days from now.
So now we will move on to the next lecture of this session on the topic of Indian experience of carbidocin in PPH prevention. And to deliver this, we have Dr. Vidyadhar Bangal sir from Pravranagar. He is MBBS, DGO, MD, DNB and PhD. He is a professor and head of the department at OBGY department at Dr. BVP Rural Medical College, Pravra Institute of Medical Sciences. He has 33 years of teaching experience as a PG teacher and examiner and also PhD guide. He has 163 publications to his credit in various index journals.
Final F kar.
He is
Final
a member
Solapur.
of editorial board of 4 international journals. He holds various positions like President of Loni OBGY Society, founder member of Organization for Women and Health Together for the Future, co-chairman of Board of Studies of Reproductive and Child Health. Also governing board member of Nationwide Quality of Care Network. He is a member of FOXY, Indian Public Health Association, AMOGS and National Mentoring Group. His areas of special interest are emergency obstetrics, high-risk pregnancy and community obstetrics and health care quality. Now the stage is yours.
Thank you, ma'am. At the outset, I thank Solapur OBGY Society and the office bearers, Dr. Virkar, Dr. Meena ma'am, Ketki, Praveen. It's a big challenge for me to have a session after Dr. Pankaj Desai, which I am facing for the first time. I'm very happy that I'm presenting this particular topic in front of senior teachers, Sardesai ma'am, Rohini ma'am, and I'm very happy to be in Solapur again. Maybe 3-4 years back, I was invited by ma'am for some colposcopy workshop in Solapur. Particularly this topic, actually there were few changes happening. Initially this was the topic, subsequently it made carbotocin. And again, I prepared the original topic, so I will be speaking on this original topic. Of course, I have included the carbotocin aspect in my presentation. Yeah. So I am working at, since last 33 years at Pravara Institute of Medical Sciences, which is situated in Loni, which is near Shirdi in Ahmednagar district, which is a deemed university now. I am heading the department since last 12 years. This particular hospital is no less than a home away from home for the poor patients of rural area. This particular facility is a Laksh Manyata accredited facility. We have International Childbirth Initiative certification. At the same time, we have some collaboration with White Ribbon Alliance. I am presenting this details about the facility because the topic relates to it, and I will like to rather share my experiences about this particular aspect of complication of the delivery and what all things we are doing at our place for prevention as well as management. So this is how I am going to present this particular topic. We have a delivery rate of around 11,000 deliveries per year. We have certain core values that we follow and that have definitely helped us in improving the quality of our services. We do have labor room protocols, obstetric protocols, and certain quality indicators which are regularly being followed. We have a 24/7 obstetric triage. I'm giving the details because it has some background about the topic. This is the labor room ambience, a drug supply trolley, labor room readiness, which is extremely important, labor room preparedness, routine practice of AMTSL, its implementation, operation theatre preparedness, debriefing sessions, a dedicated team at work, labor room, as well as operation theatre. They are all the time ready to deliver the services. It's very important to have training sessions for all cadres of healthcare workers, which we are regularly following, and adding up to all the new gadgets that come to our maternity care services. Training sessions, as I said, everyone has to be trained. Training is an important component. That's how we improve upon the outcomes. So these are the background of my particular facility where I am working and training and trying to involve everyone who are working at delivery ward. We have good linkages with the periphery. It's a district, one of the biggest districts. Solapur, Thane and Ahmednagar, these are the 3 big districts in Maharashtra. We are one of them. And knowing that the referrals always come from all over the district, we have a good linkages through our OBGYN society as well as many of our students and my long stay there. It has helped me to develop these linkages. All the primary health centers, rural hospitals, sub-district hospitals and private maternity homes are very much attached to the department through a helpline, which is a dedicated helpline, no intervention in between, directly phone call comes to labor room since last 7-8 years. In order to reduce the postpartum hemorrhage as a prevention, we thought over our data and even literature suggests that postpartum hemorrhage is more common when there are either medical or operative interventions in the process of labor. Postpartum hemorrhage is one of the things. if we thought of induction of labor or intervention, whether instrumental deliveries or C-section, postpartum hemorrhage is on a higher percentage. So, since last 2 years, we have thought of reducing the C-section rate using various parameters, criteria, supervisions, and thinking of natural birth, what can be done to reduce C-section rate or interventions, unnecessary medical interventions. That is sort of an epidemic all over the tertiary care hospitals and the medical institutes. Unnecessary interventions in the labor room are really a matter of concern, especially inductions, augmentations and C-sections which can be avoided, and these happen for various reasons, but it's time that we think about it and actually try to reduce the C-section rate, think of natural birthing as one of the safest ways to reduce the complications of labor. Government of India is also thinking of bringing back a new cadre of specialized people, that is midwives. Many times we just associate these midwives with our nurses, but it is not so. These are very highly qualified, educated, skilled manpower that needs to be there in the labor room. We obstetricians are maybe very few in the tertiary care hospitals as compared to the total load that is available, and having this trained, skilled, full midwives will definitely help us as obstetricians to reduce our stress, reduce our physical burden in the labor room. So, last 2 years I am also improving on this aspect and started using birthing tools and alternate birthing positions which are likely to reduce C-section rate and improve vaginal delivery rate. So, I am using these birthing tools in the form of a birth ball, peanut ball, rebozo, comfortable upright birth support, grab bar and birthing stool. So, what are these? I will just show you the pictures. It's just an experience sharing that what I am doing at my institution. Many times just observing others doing, we can also learn. It's not necessary that we have to do, but subsequently once we get little confidence, we can start doing that. There are definite benefits of birthing tools. They are simple, low cost and effective tools to accelerate process of labor. They reduce the duration of labor. They reduce the episiotomy rate and instrumental deliveries. Maybe 3 years back, my tertiary care hospital episiotomy rate was 87%, and I was surprised. At the same time I was feeling very bad because it was not properly analyzed. Now all these interventions, it has dropped down below 50%. Even today for primary gravidas it is still around 60 to 70%, less 30-40% are without episiotomy, and for multis it is around 10%. So looking at the quality indicators, intervening, doing certain things and trying to ask our subordinates to do that and follow that definitely helps us in improving our outcomes. Again, last 2 years I am put on various birthing positions which we know that upright birthing position is much better than the supine or the lithotomy. If you go into the history, it is said that it is the obstetrician who brought this supine position into as a culture of delivering women in the labor room. Last 300 and 400 years only this supine or lying down position has come up, but before that it was all upright position. These are classified as either supine positions or upright positions, supine being lateral, dorsal, semi-recumbent, lithotomy, all fours, upright being sitting, kneeling, squatting positions. All these upright positions are being implemented at Praura since last 2 years. This was the ancient birthing position that we all see. This is another sitting position, and the physiology behind that, it's a J shape of the birth canal, asking woman to lie down and then push against gravity. We are not taking help of the gravity that nature has given to us when the woman is either sitting position or in upright position. The amount of force she has to put to deliver that baby, to push that baby is much more when she is upright position. That is what is the simple physiology, and that what we have observed, and I am put those observations which I will be presenting in FIGO conference Paris in November. These are the peanut ball which is being used in our labor room. This is the rebozo, that is one which is woman is holding. That is also for pain relief as well as helps in descent of the fetal head in the birth canal. So this is the squat bar, which is a bar, horizontal bar attached to the lower end of the labor table. Woman is sitting and then she is pushing, using the squat bar. Another is that another simple thing that she holds into and then tries to push rather than lying down. This is a steel chair. Originally it was a wooden chair which got broken after 170 deliveries on that broken chair. But then I made a steel chair with some design, different design, lateral part aspect of this, and then now almost 1,000 deliveries have been conducted in last 1.5 years on this birthing chair, and the results I will just show you. This is the one on the left side was a wooden chair, got broken, then I have made this, and now that is being used. This is the birthing chair unit in my labor room. This is the rebozo for holding. This is a grab bar. They are my residents conducting deliveries on sitting chair in the second stage of labor. This is the early initiation of breastfeeding on the chair. There is absolutely no woman is very comfortable. Within half an hour of her delivery, she is on her own feet and goes to the observation room. There is another patient who has delivered. Placenta is still in. Baby is given for early initiation of breastfeeding, and then we have an experience sharing session of alternate birthing positions with these all women at the same time there in our postnatal ward. How much is their experience? Since it was also our very initial experience, we thought that we included only those women who had first delivery in the lying down position, and now they are a sitting position, and we just asked them to compare their initial experience of lying down versus sitting position or upright positions, and the experiences which I have actually video recorded. With the time constraint, I am not able to share with you. Now, in last 1 year, I have around 2,230 deliveries, and these are upright birthing positions, either sitting, squatting, or reclining position, and these are the numbers. And since my residents also got now confidence of doing this in alternative positions, the number is going high every day. These are the deliveries which are kept in reclining or propped up, deliveries in squatting position, and the total. Now I just try to analyze the soft tissue injuries in these 912 deliveries who were delivered on chair, sitting on chair. The results are almost identical or much less. Some of the figures are much less than the supine position. Okay, the perineal tear, first degree 6%, second degree 3%, cervical tear 0.4, paraurethral 0.1, vaginal lacerations 0.2. Only thing is, for the initial 500 deliveries, I had two parameters to be considered while asking them to deliver on chair. One of them is baby weight less than 3 kg and multigravida with previous normal deliveries. So these were the first 500 deliveries. Subsequently, now even 3 days back, there was a delivery of 3.6 kg, 3.8 kg, one was 4.2 kg, which had a second degree tear. Again, I asked residents to limit the allowing women to be on this with such a big baby. Okay, because we don't want any third degree tear to happen, just to show that we can deliver them in upright position. And of course, various 10 maternal outcome indicators are compared with horizontal supine, sitting, squatting, and semi-sitting. Similarly, perinatal, almost 10 perinatal indicators have been compared with these 3 different positions, which I will be presenting subsequently. And maybe our hydrolabor unit facility is also ready to be inaugurated next week. And we are now adding this particular facility to our labor room. Coming to the main topic, that is postpartum hemorrhage. So this is what I told you, because it was a prevention of postpartum hemorrhage, not only the management but the prevention. I feel that by reducing the unnecessary operative interventions, we can definitely reduce, and for that definitely we have to work little more for natural birthing and taking help of various positions and maybe tools, so that women deliver more naturally rather than. For me, even today, being a tertiary care hospital, my C-section rate is around 34 to 36%. When I compare it with many tertiary care hospitals, they have already crossed 50% and 60%. So I am quite happy, although I further feel that it should come down much below 30%. But due to certain reasons, being tertiary care hospital, the C-section is at present, last 4-5 years, it is in between 33 and 36%, which I feel for a tertiary care hospital is quite satisfactory. PPH, when we say it's a bleeding from birth canal at a rate or amount that has the potential to deteriorate the condition of the mother and cause hemodynamic instability and shock. Now what I have shown you is all because of this quality PPH emergency care, which is not only the infrastructure, but lot many things are required if at all we want a better outcome. What is that? Facility readiness, which I have shown you, all the things what are available in the labor ward. We need to have network integration, that is people we need to connect with the surroundings, teamwork and communication within the hospital, outside the hospital, and of course we should have good PPH emergency clinical care in the labor room. Now what is new is maybe you might have also heard about the concept of PPH bundles approach. WHO is recommending certain bundles for the management of cases, and this is something called a PPH bundle approach, which starts even after doing for example active management of third stage of labor, and we have called for the help. There is if there is a PPH occurring, mainly whatever, maybe a tonic or a traumatic, we need to have certain immediate interventions to be done that we fall. All those initial interventions we call it as first response bundle. It's a bundle, there are two parts. First is a first response bundle, what needs to be done immediately, and in that there are 4 things which are said by the WHO. One of them is of course immediately once we notice that there is a PPH, what is there to be done is the uterine massage. Second is to start IV fluids. Third is uterotonics, and we have recently added tranexamic acid as a evidence-based medicine for immediate control of postpartum hemorrhage. So these 4 measures when done together in all the cases, that is what is a bundle. That's bundles approach. So first response bundle comprises of these 4 things to be done in all the cases immediately. And of course in the second half there are 3 more additional supportive measures that needs to be done. One of them is of course it is the treating the lacerations, that is trauma, then emptying the bladder and emptying the uterus if at all there are some tissues or membranes or the placental bits. So these are the 7 things that have to be done, 4 immediately and 3 as supportive measures. Now we'll go one by one into this, and there are few additions in the form of drugs that we have added recently in place of oxytocin. We all know about the active management of third stage of labor, and it has first thing is to be done is the use of oxytocin, which we have replaced by carbetocin now. Then of course there is a controlled contraction and delivery of the placenta, followed by uterine massage. So these are the 3 essential measures for the AMTSL. Coming to prophylactic uterotonic medications, WHO has recommended oxytocin, misoprostol, and of course the methergine or the ergometrin. Recently it is observed that among residents or maybe junior faculty feel that methergine or ergometrin is a contraindicated drug for the use of in the third stage of labor or for the control of PPH. It is not so. They have sort of a lot of fear factor developed. We all, majority of us, all teachers, routinely used for thousands and hundreds of thousands of cases methergine. We never came across such coronary spasm, and I am not saying that we should give as a first drug, but of course it should be there in the labor room, emergency drug trolley, and whenever it is needed, when other drugs are not really helping us, we should use it without much fear. So this is about the uterotonic. And controlled contraction, we all know it is must, and uterine massage, how it is to be given. These are the 3 more additional interventions. Look at for the trauma and treat that trauma, empty the bladder of course, and put the baby to breastfeed. If even after AMTSL there is a bleeding, then call for help. And now, if there is a PPH, first response bundle, which I said, uterine massage, IV fluid, uterotonic, and tranexamic acid. Uterine massage to contract the uterus and express clots, IV fluid, normal saline or Ringer's lactate. Coming to uterotonics, oxytocin is recommended for control of postpartum hemorrhage. Uterotonic drugs, they are of 3 types, posterior pituitary extracts, ergot, and prostaglandin analogues, which we are all knowing and routinely using. Now I am talking about the carbetocin, which is mainly recommended only for prevention of postpartum hemorrhage. The recommended dose is 100 microgram intravenously, slowly. And there are very few contraindications like severe hypertension. That has to be kept in mind when we use it for prevention of postpartum hemorrhage. These are the first line agents, and second line agents are ergots and prostaglandins. Oxytocin is considered as a gold standard treatment for the prevention of PPH, but it has certain drawbacks that we have come to know, that it has a shorter lifespan and it needs refrigeration. Without that, the potency of oxytocin won't be there, and of course, if the potency is not there, whole purpose of administering that pitocin is not there. So either you maintain the proper temperature or the potency, which is a big issue, may not be in the private hospitals, but in the public hospitals, electricity is a problem. There are no electricity backups, and then we get cases of postpartum hemorrhage from public hospitals, and really nobody goes for the finding out the potency of the drug. Potency test. At my place, we are regularly sending every year some batch of oxytocin to Bangalore for potency test, and we are getting that whatever we are using actually from labor room is potent drug, and it's not lost its potency. Of course, so some of the advantages are there with the carbetocin, although the cost factor still exists, but there are definite advantages that it's a longer acting, single dose of administration, devoid of repeated administration, superior efficacy, similar efficacy as that of oxytocin. It is superior side effect profile over oxytocin. So since last 10-15 years, we were thinking and hearing about the carbetocin coming in the market. Ultimately, last 2-3 years, carbetocin is very much there in our hand, and if possible, since it has a better efficacy, longer duration of action, no hits, especially hit stable carbetocin, we should go for it when our cost factor is not very important. It acts by oxytocin receptors, which causes the uterus to contract, and there are many studies which show efficacy of the better efficacy and action of oxytocin over carbetocin over oxytocin. These are some of the, even WHO recommends, not as the first drug, but yes, it is there in the list of WHO's oxytocics that carbetocin can be used. Is recommended by WHO as an effective uterotonic in its 2018 guidelines. This is last 1.5 years, I have used now till date around 12,000 doses of carbetocin, which I will be presenting in Hyderabad. I have around 1,000 deliveries per month. Almost 60 to 70% of my patients are getting carbetocin, and the data is quite big. The denominator is almost reaching 12,000 now, and it's time for me to really analyze it and have some robust information about carbetocin and its efficacy or maybe superiority over oxytocin and other drugs. So this is just 6 months back. This was the data which I had compiled. At that time it was around 6,600 doses of or cases of in which I had used carbetocin, and various parameters that were analyzed was primary atonic for the prevention of PPH, of course, as a measure in the AMTSL. Primary atonic PPH, need for additional uterotonic, need for blood transfusion in those cases, average amount of blood loss. All the low risk as well as high risk cases for vaginal as well as C-section were separately analyzed, and then we found out, so we had drawn some conclusions. One monogram has been printed, and that shows more details. I won't go into the details of those analysis and the findings of this particular Indian clinical study. But the data is being further on day-to-day basis is being compiled, and various factors are being added, considered while we compile. So low risk pregnancy, high risk pregnancy, then high risk patients having high risk factors during emergency section, high risk factors during low risk cases for requiring emergency cesarean section. So all those are cases with elective C-sections. All these we have analyzed, and now we have come to some conclusion saying that yes, carbetocin has a safer safety profile, and of course it is effective. In a busy hospital, as we all know, being teachers, many here, patients after labor room goes to postnatal ward for 2 years for maybe very short, brief postpartum, immediate postpartum observation we do, and then patients go a little away from our observation. Residents cannot all the time sit there, and maybe nurses may not be, nurses are also overworked. Many times PPH happens after 3 hours, 4 hours, and then we are in big trouble to shift that patient again back to either emergency room. So it is always good to have a drug which has a longer effectiveness or longer duration of action, and which does not really need refrigeration, and that is the main advantage of carbetocin. Although I said that cost factor is always there, and maybe over a period of time cost will also come down and we'll have this drug which is economical also. These cases of 6004, we just compiled the side effects and we found that yes, it has a safety profile, our safety margins are very high, and that very well we can replace oxytocin by carbetocin. Then we go for tranexamic acid, which is now almost accepted regimen for using in postpartum hemorrhage, not for a prevention but of course for control of PPH. Then after this first response bundle, which I already said, and the supportive measures we have done, we have to check for tears, empty the bladder, empty the uterus, refractory PPH interventions. If even after having those 4 interventions done immediately together, combined, even if after that there is a PPH, then we label it as a refractory PPH, and the interventions required for that are either bimanual compression, intrauterine tamponade, use of NASG, that is non-pneumatic anti-shock garment. And afterwards there are, of course, since the patient has bled really and it has gone showing some deterioration in the shock index, then we need to have blood transfusion. And of course, if you are working at a private hospital or in a public hospital, lower level facility, we should try everything possible to shift the patient to a safer place as early as possible. So these are the interventions, that is refractory PPH interventions, that the trigger is atonic postpartum hemorrhage not getting controlled by our routine first response bundle. Then we have to think of refractory PPH and start immediately doing that. Now these are the 3 components which I have already said, and the supportive measures. Let's now see how to manage that. Of course, whatever we have started in the first response bundle must continue. It's not that refractory PPH, all that we stop pitocin drip and this and that. That must continue, and what we are doing. And now we need to continue with fluid resuscitation with normal saline or lactated ringers, give second dose of tranexamic acid. If the bleeding does not stop within 30 minutes, continue oxytocin infusion. Okay? And then of course, contact blood, critical care specialist, because it's time now, the time is running short and we must act rapidly so that patient further do not deteriorate. What are they? Compression sutures, intrauterine balloon tamponade, non-pneumatic anti-shock garment, which I already said. I won't go into the details, but we all know that 2 compression maneuvers are most important, and one of them, and this must be our skill training to our residents, not only residents but even interns. They must be told about these compression maneuvers. One of them is of course aortic compression and bimanual compression. These are useful, their efficacy is proven, and that must be told. That is what is now in our competency-based curriculum. This particular aspect has been covered, saying that at least interns, they must know how to do this, because they could be the only people at the periphery also once they finish their internship at the public hospitals, and they must know this essential and life-saving simple maneuver. So procedure I won't go into details. This is another very important aspect of PPH management that many of us at that point of time forget. Aortic compression. It's abdominal aortic compression, either from abdominal wall or maybe uterus, abdomen is open during C-section, and if there is a profuse bleeding, or we just come across some placenta accreta syndrome, okay, spectrum, any case, and immediately patient starts pouring. Many times in a busy maternity unit, the patients are unbooked, directly coming, and immediately without adequate investigation, even ultrasound, they are taken to OT, and then we are surprised to see this thing happening. So at that point of time, it is very important that the team who is operating must know something about aortic. It gives us time for some expert to come and deal. So this aortic compression is extremely important, and this is the picture showing aortic compression. It is how it is to be done, and with the help of the fist, we have to just compress, go deep enough, just above the umbilicus, and where first palpate the aorta, put your fist there, compress. At the same time, other hand should be there on the inguinal region, feeling the pulsations of the femoral artery, and if there is an effective compression, femoral artery pulsations will disappear. Many times this is required when patient is already into hypovolemic shock, even the femoral pulse could be feeble. So that has to be kept in mind. But disappearance of the femoral artery after putting adequate compression is a sure shot indication that you are at the right place and the pressure is adequate. So even if there is aortic compression for some time, maybe 15 minutes, 20 minutes, till the expert arrives into operation theatre, that is not going to harm the lower extremities. There is adequate evidence that this is a temporary measure but very effective measure to control pelvic hemorrhage in any such situations, especially what we are dealing these days is the placenta previa, placenta increta, accreta, percreta, rupture uterus. These are some of the situations. Broad ligament hematomas, extended call for access, all these are the situations where there is likelihood of this happening. So it's a very effective measure and it has to be taught, and many times it is not been taught. I don't remember any time during residency somebody even said about maybe 30 years back, 35 years back about aortic compression. But we have known now that it is a simple measure, and if it is one example that maybe almost 2 years back, one of my senior resident called me in operation theatre at night time, and that saying that, sir, this is a severe bleeding, placenta previa, and he was unable to control. So immediately he was done his PG from Aurangabad, and Aurangabad is known with Dr. Gadappa there. A lot of these skill-based trainings are being carried out, and he had luckily put all the aortic compression till I arrived in the operation theatre. Maybe I am staying in the campus around 10-15 minutes I reached there, but till that time he did that and patient was saved. Till we did the obstetric hysterectomy, the hand was not removed, although he had all the cramps for that time. And of course he was operating, but he asked some resident to do that. But knowing that yes, this is to be done immediately, that has to come to the mind of the operator, and then only we are able to save these lives. Coming to this NASG, non-pneumatic anti-shock garment, that is another addition to our labor room, and that is usually helpful in either preventing the shock, or even if the patient has gone into shock, preventing further deterioration of the shock condition. So NASG has all those segments, and I have kept the NASG in the casualty because tertiary care hospital, all the time patients come from different areas. So it's there in the casualty, in the ICU, in the labor room, in the operation theatre, or floor places. I could convince my management that yes, it is required garment, and then we have all those at various places. So NASG is one of it doesn't cost much, some 7,000-8,000 rupees, but it can be used for 100 cases of PPH. Not only that, but I am also Loni OBGYN Society President. I convinced my gynecologists in the area, almost 40. So we bulk purchased 40 garments and gave it to them, and telling them that even if you have a PPH, you send the patient with garment, I will see that you are not being, you are saved for whatever medical litigations, because you have done your best in whatever was in your hands. So this is how NASG has to be there for all practitioners, in which case it's not only high risk pregnancy cases, even low risk pregnancy cases can develop PPH, and we are in trouble. So these are the things. Uterine balloon tamponade, there are different tamponades. I won't go into details. Many times we have those skill workshops in which UBT is also used. This is non-pneumatic anti-shock garment, how it looks, various segments, they are put around the body, lower body, and it has a physiological principle that it takes away the blood from the lower extremities toward the vital organs, so that patients, at least vital organs, that is brain, heart, kidney, liver, they are spared till the patient it's a temporary measure, but of course it helps the patient to reach to the safer destination, and that's how NASG should be used, and that is being used in my area. There are various indications, and there are certain, of course, it's a very simple thing. Our nurses and these are the patients where this is being used. This is the incorrect application, this is the correct application. This is the patient with NASG with Bakri balloon and UBT. These are the patients being shifted on NASG. This is the post-op recovery of the case, NASG in hemorrhagic shock. There is a method of particular removing and cleaning that you can read. And of course, other measures which are necessary in refractory PPH is blood transfusion. And as Dr. Sir has said, that there are definite indications of blood transfusion, transfer to higher center, indications for transfer, and I won't go into the details of surgery that is required, which is required for atony, soft tissue injuries, retained placenta. These are some of the measures that we all do. These are some of the additional indications for doing surgery in postpartum hemorrhage. general principles. Do not panic, as it has been said. Call for help. Who going to panic? Those who don't know, those who have not experienced, those who are not exposed to such gatherings, those who do not attend skill-based trainings. These are the people who go into panic. Perform definitive surgery, replace adequate blood components, arrange for ICU admission. So with this, I stop my presentation, and thank you very much, Solapur Society, for giving me this particular opportunity to share my experiences. Thank you very much. I acknowledge Professor Thomas Burke from MGH Boston and Professor Maria Fernanda Escobar because I got opportunity to visit their critical care centers through Harvard University 5 years back, and lot of new learnings took place when I visited these places. It's all obstetric critical care unit. Thank you very much.
Thank you, Professor Vidyadhar Bangal. It has given really a good insight into right from primary care to tertiary care of PPH, and some very new ideas about delivering the patient, taking care of her. If anyone has any questions, please go ahead. Yeah, he says we are speechless. It was a wonderful deliberation.
Now I request chairpersons to felicitate today's speaker, Dr. Vidyadhar sir. Dr. Pankaj Desai sir. Felicitate our chairpersons, Dr. Doshi sir. Dr. Madhura.
One question to Dr. Vidyadhar, please. I just want to know whether can we give pitocin. The pitocin drip is running, the patient is delivered. Later on, whether can be combined with the carbitocin for management of third stroke labor. With pitocin.
Carbitocin is recommended only for prevention of PPH and not for management of PPH.
Oh, but then it cannot be combined like. So,
it is said that after carbitocin, usually there is no, even after use of carbitocin. If we get a case of postpartum hemorrhage after the use of carbitocin, which I haven't yet got, one case was there of PPH maybe 3-4 months back, which went to from delivered in our labor room but shifted to SICU, and then I was surprised when I have almost all clear instructions about use of carbitocin, and in that particular case which went to ICU for hypotension due to PPH, the carbitocin was not used. So I have yet to get a case of proper documented postpartum hemorrhage after getting carbitocin. So, of course, it is not written that we should not use other additional drugs. We should use, it's a life-saving condition. So it is not that carbetocin is 100% giving efficacy. If required, it should be, other drugs should be added, and there is, I haven't got any study about use of other oxytocics after carbetocin.
No, she is asking, patient is on probably induction or augmentation, she is on oxytocin drip. And after she delivers, whether that oxytocin is going on, along with that, the other side, whether carbetocin can be given.
Carbetocin can be given. It's not a contraindication. They're all same oxytocin analog. Carbetocin is oxytocin analog only. There is no cross reaction or any synergistic anything. So it can be used. That I have not studied, ma'am. That I have not studied.
Yeah, I think what has happened is that when you give oxytocin for a longer time and the patient is in labor, some of the receptors get blocked because of longer use of oxytocin. These are the patients who may benefit with use of carbetocin, but don't give both together, according to me. Ideally, you should not use two oxytocics together, ideally. There was a time when methergine was available, as he very rightly said. We used to give in treatment of PPH, oxytocin going on 20 units, 30 units. Methergine also people used to give, and then they used to give also carbetocin, carboprost. So that was a different issue. But when it comes to augmentation, you have to be very careful. Yeah. Absolutely not. Absolutely not.
After that you can use carbetocin. After 4 minutes you can use. Receptors are same. Yes. Pitocin you can stop. Oxytocin is having only 4-minute half-life. If you use carbetocin, then you can't use oxytocin. Because carbetocin is having 45 minutes half-life. Yes, that is the difference.
So by the time you get carbetocin, your oxytocin effect is gone. So you can give it immediately, but not the other way. Obviously, because the uterus is otherwise you will rupture the uterus. You will rupture the uterus if you use such high doses. So 2.5 units for multis and 5 units for primi.
All are invited for the lunch.
Now we begin our post-lunch session. For this session, I call upon our chairperson, Dr. Sampath Baldava sir. He is the director of SS Baldava Neurosciences and Women Care Hospital. He is HOD of OBGY, Department of OBGY at Solapur Sahakari Rugnalaya since last 40 years. He is faculty at many national and state conferences. He has won Best Paper Award at AMOX 2022, and he is a life member of FOXI and IMA. Our second chairperson, Dr. Lata Patil. She is a consultant gynecologist practicing since 20 years. She is a consultant at Mitanshu Hospital, working as a gynecologist at Boys Corporation Hospital, and a medical director at Markandeya Rugnalaya. Over to you, sir.
Hello, good afternoon everyone. We are starting post lunch section now. Dr. Pankaj Desai sir is going to speak about this. Sir has introduced already by Dr. Babuli Doshi. Just in short, I wanted to tell about sir. He is an academician, is an excellent teacher, scientific researcher, inspiring public speaker. In 1985, myself and Dr. Babuli Doshi went to Ahmedabad for a conference. At that time, we heard Dr. Pankaj Desai sir on PI something. Very excellent talk, very beautiful and a very short talk. And from that day, myself and Doshi has become the fan of Dr. Pankaj Desai sir. And next, anytime, any conference, we used to find out where is Pankaj Desai sir, and we wanted to hear him. Such a excellent teacher he is. Yes, I am requesting sir to talk on this. Thank you, sir.
ये चालू करूँ का? Thank you. We will start with a prayer as usual. We reverently pray for eternal harmony in the universe. May the weather be seasonable. May the harvest be fruitful. May countries exist in harmony. And may all people enjoy happiness. Honorable Chairpersons, Mr. President Sir, Madam Secretary Sir, Madam Secretary and friends, this is an entertainment program. You are not going to learn anything which will help you in your practice. Because, before I come to because, all your questions and all, I will prefer it if they come on this, because you will take time to process the information. Many things will be very new and original for you, and therefore go home, think about it, and then ask me. But there are raw questions, today clinical questions, such excellent were coming. In the previous sessions, they were very clear that because you face that day to day, this is something different. But when I am talking on a non-academic topic, I would like to make one thing very clear. I don't see myself as a life coach. No. I am not even a mentor or a guide. I have no such illusions. I don't intend to give self-help lectures. You must have heard many self-help lectures, self-help books, read books. No, there is nothing to do. I am not qualified to do all this. This is a semi-autobiographical lecture, sharing the philosophy and actions that have helped me. And therefore I want you to be helped. And not only me, but millions others. And it has not come from one source, but it comes from many sources. And therefore, many times I get emails, sir, which is the source? You will not get the source. But you can ask me. And if sir sends me the recording, I'll be very thankful to him. I intend to put it on my YouTube channel and will share with you people as soon as it is uploaded. Because self-help lectures are intended to make you materially more successful. Meaning earn more money, get a bigger name and fame, get a higher post. If you are a resident, become a senior resident, your behavior becomes such that you are taken up as an assistant professor. No. And get more and more promotions. This is absolutely not going to do anything. Then what is it going to do? It is going to make you more happy. It is going to make you more joyful. Happiness and joy are two different things. Happiness is khushi. Joyful is anand. Happiness usually needs an extra source. The pastry this afternoon, which I took, sir, gave me happiness. That happiness came from the taste. But joy just comes like that. You are in a particular situation and you feel a romance. It goes away. What produces it and all, science has not been able to decode. But its reality is accepted. Levels of serotonin, levels of oxytocin in your body and all that has been checked. So this lecture can help you to be more joyful, be more at peace, and be more satisfied. It will not help you to earn a single paisa more. So if you are looking at that, say a lecture on Caesarean section or a lecture on PPH, or you manage excellently or that iron, it will help you to earn more. This is not going to help you more. But what will happen for sure is, when somebody meets you, that person will feel he has come home. This is ultimate. तुम्हाला असं वाटेल का हा माणसाला भेटून मी घरी पोचलो. I am home. See this child and see the father. The father has reached home and see the happiness on their face. Both of them. They have reached home. Therefore they say home is a place, is the only place where you don't need to run away from anything. So many times from your department you want to go away, and if your home makes you run away, that is not home. I have seen individuals whom you meet, you feel you have reached home. And that is a new concept. And these are the days of New India and so many new things. The new G20 yesterday has become G21. So let us make a new you. Let us find the new you. Okay, ready? Yeah? Thank you. And for that I'll tell you a story. My age is like that of this gentleman, of a grandfather. And what do grandfathers do? They tell stories. Effective stories, skillful stories, powerful stories. My grandma's stories, I still remember. All of them. Ashamed of its flaw, the leaking bucket always made half empty, made home half empty. It started becoming depressed and becoming less and less talkative. One day, the farmer who used to carry a non-leaking bucket, a perfect bucket and a leaking bucket, saw this change. So he struck a conversation with both the buckets. He told the imperfect bucket, have you noticed that beautiful flowers have sprung upon the side of the path where you are taken, whereas on the other side, there is nothing but earth and stones. You can see this. This is the path where that imperfect bucket was taken on, and this is the path where the perfect bucket was taken on. I planted seeds on your side, and every day you watered them by your so-called imperfections when we returned home together. Over the last few years, I have been picking up some of these flowers to decorate my house or to offer to God. I am not able to get anything from the opposite side. Without you, I would never have been surrounded by such beauty. The perfect bucket, who was also listening, lost for words, looked at the imperfect bucket with great envy. She became envious. So that's where a different perspective comes in. Like the crack in the bucket, each defect is at the same time a virtue. We always gain something with each loss. I will show you the power of imperfection. This is a perfectly green picture. See this, a perfectly green picture. You don't enjoy it, but now see, when we remove the perfect green, see, it has become so beautiful. Why? Because there are so many imperfect color combinations which have come in. So many. I'll give you one more because ladies are sitting here. See this saris. They are all orange. Undesigned, all orange. Will you take them? And for these, you will pay thousands and thousands and even lakh of rupees. Saris now, पहनाने के 1 लाख रुपए लेते हैं कई लोग, है ना? So because these saris are imperfect. So therefore, when you are new, be comfortable with imperfections. Imperfections are parasmani. They are touchstones. Your most beautiful happenings and individuals are imperfect. Take my word. Perfection is very boring. Very boring. As soon as you are comfortable with imperfections, yours as well as that of the world, not only of you, but even of others, see the happy that you instantly become. Tight. I wrote nearly 15 years before this blog, which has been read by so many people. After I saw the film, The Black Swan, one of the finest films I have seen in my life, where the director gives a message that be perfect with white as much as you are perfect with black. These are my blogs. So many people are reading it. But then, long back I sensed it. Now look at this. All angers arise out of your intolerance for imperfection. You are intolerant to something which is so much normal. ये क्यों नहीं किया, ऐसा क्यों सिटी हॉल में ये क्यों नहीं लिखा, वो क्यों नहीं लिखा, ये क्यों नहीं किया, वो नहीं किया. Just recollect the events where you lost your cool. 8:30 you enter and your senior resident is not standing there to give you round. In a perfect situation at 8:25 he should have been there. But he got busy somewhere. You expected perfection. And therefore you become angry. See your angers with your spouse, with your children, all of them. And see the imperfections which you didn't tolerate. Because something happened that was not to your expectation, basically your expectation was that of perfection. Go home and think over this. What makes you this? Your craze for perfection. Perfection doesn't exist. Excellence is your job. Perfection is God's business. If you are comfortable with the imperfection, your anger has no business to arise. And I have seen it and experienced it. Madam tells me many times, you just don't get angry. In the last 15-20 years since you retired, I said there I was an administrator, therefore I had to expect perfection. Here whom I am expecting perfection from our own setup? So let it be. If it arises, just think of wabi-sabi. Those who don't know, I am introducing a Japanese word and see how it dissolves. This book, please, I recommend if you have interest in reading, read this book, Wabi-Sabi. This is a most beautiful Japanese way of a practical approach to life. It gives you instant peace. and evolves you by miles. ठीक है यार. Become new. Become comfortable with imperfections. And how to express it? There is a very powerful way, but very simple way, a very simple method. 3 words. कोई बात नहीं. No problem. Try it. Try telling that to your husband or your wife. Try telling that to yourself. Arey yaar, 15,000 rupees I lost. I have lost 4.5 lakh rupees just 1 year before because of some cyber fraud. The police is behind it and they are catching it. The first reaction my wife said was, कोई बात नहीं, एमा શું થઈ ગયું? We have not lost you. You have lost a bloody 4.5 lakhs. How much time will it take to earn? Last, what is the normal response? Why did you do this? Why did you do that? My teachers nearly lost. He is at 90. He nearly lost 5 lakhs recently. And he was very upset. I rang him up. I said, sir, this is a turning pitch. The ball just flicks off your bells. And that is the cyber world. Don't think you are very smart. Then you are not cheated. The next day you will be cheated. It's a fast turning pitch. So be comfortable with it. कोई बात नहीं. Try this word. मैं कोई गुरु मंत्र नहीं देना चलता. No problem. Such a beautiful word. Now see this. Imperfection is related to imperfection. I am showing you a video which is must be the response of nearly all of you when you listen to a phone call. Don't you start running? Hey, phone. A phone call is not an imperial command to talk with the caller. No man Draupadi Murmu or Narendra Modi is ringing you up. Accept it. It is just a phone call to talk with a request to talk with you. Don't run for it. For nearly 10 years in our family, there is a rule that mobile phones are not taken on the dining table. It can ring. We don't put them on silent mode also, we will ring again. That black shining rectangle box which is lying there currently on silent mode since 9 o'clock. Has it become your black hole? Think. I started putting my phone out of sight. When my mind is even slightly resisting a task, I start looking for such distractions. You also must be doing it. I started seeing my smartphone for what it really is. Identify. There are many such distractors in your life. Identify them. Eliminate them. It improves your focus and awareness. I promise. It has helped millions of people. Thich Nhat Hanh, who recently died, the great Vietnamese philosopher about mindfulness, he was the propagator of mindfulness, of awareness. Try it. Very small thing. Use it at the right time. Don't need to run for it. And the next, handling the race of life. The race of life will neither add life to your years nor years to your life. Add life to your years. Let your life be necessarily big, but not necessarily long. You just can't make it long. Then why not make it big?
क्या जानना चाहते हैं? कम से कम बीमारी का नाम तो बता दीजिए. बीमारी का नाम जान के क्या मिलेगा? मिलेगा बताना जरूर पड़ेगा. अगर मैं कहूं कि आपको लिम्फोसार्कोमा ऑफ द इंटेस्टाइन हुआ है, तो आप क्या समझेंगे? क्या? फिर से कहिए. लिम्फोसार्कोमा ऑफ द इंटेस्टाइन. वाह, क्या बात है, क्या नाम है. ऐसे लगता है जैसे किसी 5 स्टार का नाम. बीमारी हो तो ऐसी हो, इतनी हो. यू आर अ ग्रेट डॉक्टर बाबूशाही. वाह, क्या नाम. लिम्फोसार्कोमा ऑफ द इंटेस्टाइन. आदमी विवेक भारती का नाम कर सकता. कसम से दोस्त, अगर ये बीमारी किसी औरत में होती ना, तो ऐसे लगता जैसे उसने किसी अंग्रेज को वोट नहीं दिया। ये मजाक और मस्करीपन की बात है। Do you know the meaning of lymphocytoma? आप जानते हैं ये किस बीमारी का नाम है? मेरे पेट में भयानक किस्म का ट्यूमर है, जिसकी वजह से मैं 6 महीने से ज्यादा जिंदा नहीं रह सकता। शायद उसी का डॉक्टरी नाम होगा। आप अचानक नाराज क्यों हो गए? ओह, समझा, आप मुझ पर नहीं अपने आप पर नाराज हैं, क्योंकि मेरा इलाज नहीं हो सकता ना, इसलिए। ये बाबू मशाय, मैं तो भाषा मालूम ना है, इतना प्यार अच्छा नहीं। बाबू मशाय, आपको चेक कर सकता हूँ? मुझे क्या होगा? भाई अपना हाथ से दीजिए। नब्ज नो चांस। आपकी उम्र क्या? 30। 100 में से 30 में कितने रह गए दोस्त? 70। आपकी जिंदगी 70 साल से ज्यादा नहीं। आपको मालूम आपकी बीमारी क्या है? आपकी बॉडी, जिस्म, शरीर, जो कि आहिस्ता आहिस्ता खत्म हो रहा है। आप कहना क्या चाहते हैं? यही कि क्या फर्क है 70 साल और 6 महीने? बहुत एक पल है बाबू मशाए। आने वाले 6 महीने में जो लाखों पल में जीने वाला उसका क्या होगा? बाबू मशाए, जिंदगी बड़ी होनी चाहिए, लंबी नहीं।
जिंदगी बड़ी होनी चाहिए, लंबी नहीं। यू विल बी टोल्ड इन 100 ways, some hidden, some openly. Keep climbing and never be satisfied with where you are, who you are and what you are doing. संतोष dangerous word है. Really? Get out of the rat race. I know of people who silently stepped out of the race that they never wanted to be in. There were some reasons why they were, and they left. They found their own lane and proceeded to win. Invest in the infinite and your journey will outlive you. These are the words of Professor APJ Abdul Kalam. He emailed this to me in a very private message. And this is when I retired from Foxy and I retired from Medical College Baroda, the same year. He told me in that letter, sometimes we used to exchange. He said, I was not regularly in touch with him, but whatever, but some beautiful lines he said, that invest in something infinite. Presidency of India will end in 5 years. Presidency of Foxy will end in 1 year. Presidency of whatever you want to do will end in finite term. Chairmanship of some committee will end in 3 years. You will retire 100% by age of 60. It is finite, it is decided. So invest in something infinite. Professor Abdul Kalam continued to teach and died while he was teaching in the mountains of Himalayas. Presidency or no presidency? 16 years before I left Foxy and Medical College, I am still invited. I still remain busy with my academics and I am booked up till March. Last night when I was traveling from Mumbai, I got 2 phone calls. I had to refuse because I had invested in something finite, something infinite. Who cares? Who cares what post I am holding? Did anyone of you read my biodata? Even I don't read. But what I am going to tell is infinite. Keep rejuvenating yourself in investing in something infinite. For me, teaching my academics is infinite. Practice we will stop one day, but my academics will continue. Posts, positions, status, and such mundane achievements are finite. How many of you remember who was the president of Foxy just say 20 years before? How many of you remember who was the chief minister of Maharashtra after Vasantrao Naik? How many of you remember who was the president of India, the vice president of India before Bhairav Singh Shekhawat? Some of you might not even remember Bhairav Singh Shekhawat. These are finite. Time will eat it away. But infinite, Kalam sir's teaching, his books, we still continue to read. Social media is a massive delusion creating platform. There is nothing good there. There is everything excellent there. Most nonsense photograph uploaded. Oh, wonderful, wonderful. Most rotten draped sari I have seen yesterday. Somebody had written, wonderful madam, why are you embarrassed about it? Even I would not have draped a sari like so nonsensely. Whatever I may know of. Keep your feet firmly on ground and invest in infinite activities which last beyond you. You may go away, but academics will continue. And for that I have read a very beautiful mantra. Give you satisfaction. If my mind can remain balanced even in crisis, this is a translation of words of Chandrakant Bakshi, which I found very relevant. He's a Gujarati, he is no more, Gujarati writer. If I can sleep soundly and laugh heartily, I mean this. Can you laugh like this? If I can feel hungry and get thirsty, if I don't have a major illness or big debt on my head, if I have one house and of my own, and under the roof of which I can eat my daily roti and dal with my family, then I will say, thank you, God. You have been very kind to me. You gave me much more than what I deserved. Santosh comes from here. Santosh doesn't obstruct your progress. Santosh makes you happy. Continue learning. I still continue. Today, I continue to learn Spanish. For last more than 2 years, I can fluently, easily read Spanish now. I am learning Zumba dance. All Wednesdays and Fridays, I do Zumba dance for 1 hour. I learn it. But that doesn't mean that if I didn't do it today, oh, Pikesha will do better that Zumba dance than me. Oh, Sardesai madam will speak better Spanish than me. कुछ नहीं, मैं मेरी मजा के लिए कर रहा हूं. I am happy. This is Santosh. This is not being in a race for anything. And the last message. The new you will respect the power of time. Those of you who have seen this film will remember this character. It is said that in the previous version, Sriram Lagu acted as Nata Samrat and he required a psychiatric support. Just as it was said that after Devdas, Shah Rukh Khan required a psychological support. When me and my wife saw this film and came out of it, my wife uttered only one word. Nana should stop acting. He cannot go beyond this. And I salute him. The way he has acted. A master. And in that there is a very powerful dialogue. And the dialogue was, now Kalacha Bhakshya hai. Your naam Kal ka Bhakshya hai. Aapka naam, time is a humongous consumer of name. It ruthlessly devours your name. Don't aim for name or fame. They just don't matter. What lives on are those small parts of you which all who came in touch with you will take from you. Be careful of what they carry from you. They will carry your fragrance, your ideas, or virtues. Today you are sitting in a particular way. Today in a particular situation, in say a PPH or a Caesarean section, you respond in a particular way. You don't quote anybody's name. When you are administering Maxwell, you remember that somebody, and I know who somebody Sardesai madam taught in this way. But her name is nowhere found. I have seen her conclusions being spoken in Silchar. I have seen her conclusions being spoken in Behrampur. But nowhere her name is there. Now काळाचा बक्ष आहे. खाऊन जात आहे नाव. तुमचं पण नाव खाऊन जाईल. Do you remember the name of your great-great-grandfather because of whom you are here? No, you don't. You don't. But you remember what they must have taught, which your father also learned and told you. And you are following today certain things. You think I went downstairs reflexively to escort both the teachers up was something of my own? That respect must have come from somewhere. So be careful of what you leave behind. People are taking away from you and they will be very happy about it. Your name, your fragrance will continue to spread in your absence. Immortality is in your ideas. The new you knows that what will never die is your idea that you give to others. I will give you another example like Sardesai madam. Today, for last 7-8 years, after the recommendation came from England, all of you started using aspirin for prevention of preeclampsia. Do you know that Indians proved 35 years before and were telling in lectures and in journals and everywhere that aspirin prevents preeclampsia? But the name you don't know. So many lives must have been saved. So many lives touched. That aspirin idea became immortal. It is directly affecting you. Let us live a valued life, a sanskari zindagi. Others will automatically follow. And let us live virtuous ideas which will continue to touch lives for generations to follow. Wherever you are, in a family, neighborhood or wherever, as Swami Vivekananda said, your character is reflected, not how you behave in trying times. Even a fool will be a hero. But your character and integrity is tested when you behave in your small times, and that is observed by others. That is the new you, that is the immortal you. Thank you, ladies and gentlemen. Thank you very much. Thank you very much. Thank you very much.
Thank you very much, sir, for very excellent on how the new you. How to become self-satisfaction, how to acquire no problem, and how to become life is more easy. Sir, it's really very, very beautiful lecture, and we'll really learn something from you. Thank you very much, sir.
During lunchtime, when I asked sir that, sir, what are you telling us in your lecture? He said, you will come to know after listening my lecture. So the new you, when we all hear you, we are now happy and very joyful. We'll lead a peaceful and happy life forward. I assure you, sir. Thank you, sir. Our next speaker is Dr. Girish Kumtekar, sir. He is a renowned consulting obstetrician, gynecologist, infertility specialist, and medico-legal consultant. And he is the best teacher to many of us. In professional practice, he is since 35 years he is in professional practice. He is practicing infertility since 20 years and medico-legal practice since 22 years. He owns a private hospital of 12 beds in the city of Solapur. He is a partner in Pioneer and State-of-Art of IVF at Navjivan Fertility and IVF Center, Solapur. He is a member of Medico-Legal and Ethical Committee, FOXY. He is past member of Medico-Legal Committee, IMA State Branch. He is a past president of Solapur OBGY Society and Hospital Owners Association. He was a faculty at 1st, 2nd and 3rd National Medico-Legal Conference at Pune. Also faculty at AICOG, Aurangabad, Jaipur, Guwahati, you are Foxy. Yes, sir. So, sir, please take over.
Good afternoon, everybody. The organizers, chairpersons, and the senior faculty in this audience. After the mesmerizing lecture of Sir Dr. Pankaj Desai, sir, it's very difficult to how to come to the ground, but as he has always advised that keep your feet on ground and getting back to the ground reality of practice. This is a very small topic I'll be covering, and I hope it gives a lot of clues for the young generation who are still sitting here about managing certain things in practice. Internal iliac artery ligation is one of the very swift procedure, but has to be carried out with precision and in emergency, and is a life-saving measure. It is a time-tested and reliable procedure, first done unilaterally in 1812 for gluteal aneurysm, entirely different indication. But Howard Kelly was the first to perform bilateral iliac ligation for bleeding carcinoma of cervix. Now, these are entirely two different indications, but now we are using this frequently, particularly in obstetric practice, as a preventive measure and also a curative measure or operative measure for postpartum hemorrhage or intra-pelvic bleeding, unexpected pelvic bleeding. Let us take a small round into how it is done, how it is performed. It's a small topic, I will try to cover it within time. Going back to the anatomy, these are the branches of internal iliac, and as you can see, it's a beautiful tree of branches rather than from common iliac, crossed over by the ureter at the bifurcation, and then coming to the external iliac, going out into the part to supply the lower limb, and then the internal iliac, which divides into anterior and posterior branch, and its various branches you can see, out of which 3 important branches are for us, that is the uterine and ascending branch of the uterine and the which arises directly from the internal iliac. What is the usefulness of internal iliac ligation? It is useful in selected cases, not in every case it is not indicated. It does not provide absolute hemostasis. This is very important to understand. You cannot be reassured that once the internal iliac ligated that the bleeding will stop completely. Why? Because it dampens the pulse pressure. It doesn't prevent complete, it doesn't give complete hemostasis, but it only dampens the pulse pressure and transforms the pelvic arterial system into a venous-like system, losing the trip hammer effect of arterial pulsations, facilitating hemostasis. So to understand this, when the artery is spurting, it cannot coagulate. But the venous blood can coagulate very easily. So what you are doing by internal iliac ligation is you are converting the arterial flow into venous flow so that the hemostasis is facilitated. And the drop is pulse pressure is about 85% in bilateral and 77% in unilateral internal iliac ligation. While the mean arterial pressure drops only 24% and 22% consecutively. What are the indications? Let me run through the indications. Prophylactic indications: post-abortal bleeding, postpartum hemorrhage, one of the most important for us, and particularly this day being related to Caesarean section. It is very important in Caesarean section because PPH these days the complications of one of the complication which Dr. Bangal enumerated nicely, and even Sir has talked about, is when to take a decision of placenta accreta, percreta, and what to do about it, and internal iliac ligation becomes very important. Atomic uterus prior to hysterectomy, abruptio placenta with uterine autonomy. Believe me, atomic uterus, if you find once and PPH is not preventable, before going for hysterectomy, it is advisable to do internal iliac ligation so that your field practically becomes bloodless and you can proceed quite calmly with hysterectomy. Abruptio placenta with uterine autonomy, abdominal pregnancy with pelvic implantation of the placenta, placenta accreta with intractable bleeding, prior to total or subtotal hysterectomy when all other conservative measures have failed in PPH. While therapeutic, before or after hysterectomy for postpartum hemorrhage, where bleeding continues from the base of the broad ligament, where there is profuse bleeding from the pelvic side wall, where there is profuse bleeding from the angle of the vagina, where area of diffuse bleeding are present without a clearly identifiable vascular bed, and in the case of ruptured uterus in which the uterine artery may be torn at the site of its origin from the internal iliac artery. This is one of the rare occasions when rupture of uterus occurs, and at least once you encounter it, if you have witnessed the ruptured uterus, particularly in tertiary referral centers. Continuing, when there are additional indications including atony of the uterus which conventional methods have failed, when extensive lacerations of the cervix have occurred following difficult instrumental delivery, where there is a significant bleeding from the lower part of the broad ligament, when there are gunshot wounds to the lower abdomen, this is another unusual indication which we don't face, in the case of fracture of the pelvis and intraperitoneal hemorrhage. So you might be wondering what if the major supply is cut down, shut off, what will happen to the pelvic structures? So why it has come into work? Because even if it is done, internal iliac ligation bilaterally is done, these are the various anastomosis that are sufficient to provide blood supply to the pelvic organs. And these are if you just to enumerate them, if uterine arteries are blocked, then right and left ovarian artery, which are direct branches of the aorta, inferior and middle hemorrhoidal, which are devoid of blood supply because of iliac ligation, superior hemorrhoidal artery supplies it, pubic branches of obturator are examinated, inferior epigastric supplies, inferior gluteal anastomas by circumflex and perforating branches of deep femoral, superior gluteal, lateral sacral, iliolumbar, lumbar artery directly from aorta, lateral sacral, middle sacral, and vesical arteries, branches of uterine and vaginal arteries. So these are the branches which stop supplying blood, but the anastomosis develops to take care of the vascular supply of the pelvis. Looking good at the anatomy, this is where exactly the common iliac, then there is the internal iliac artery, and the external iliac artery goes to the obturator fossa to supply the limb. And then there are two branches, one is the posterior branch of the internal iliac and the anterior branch. And that is more important, we ligate the anterior branch of the internal iliac artery. This is the exact location where it is ligated. Coming to the procedure, This is going to be a very brief lecture because it is short surgical procedure. We had actually three approaches. One is the intraoperative where the abdomen is already open. You know where the infundibulate pelvic ligament is there. The uterus is preferably exteriorized. We are talking of iliac ligation in our obstetric emergency, that is postpartum hemorrhage. If not, then the uterus will be a pelvic organ, and then the infundibulate pelvic ligament is easily identifiable, and internal iliac is easy to dissect also. Uterus is preferably exteriorized and pulled sharply on the opposite side. Internal iliac artery is exposed by incising the pelvic peritoneum parallel to infundibular pelvic ligament, extending laterally and upwards. Now it is difficult to imagine, but easy when once you have started open and you have pulled the uterus on one side, the infundibular pelvic ligament is exposed, and then you really get the reach where you have to excise open the peritoneum, posterior peritoneum. If difficulty is experienced, common iliac may first be identified. Sometimes you cannot approach the internal iliac directly. The easiest way is to approach the common iliac and trace it downwards. Care must be taken to identify ureter which crosses at this level. So if you open the peritoneum at that level, at the level of the common iliac, then naturally the ureter will be lifted along with the peritoneum, and there you have to be very careful in identifying the ureter, isolating it, and then tracing the internal iliac downwards. This is the approach which I always advocate, and is probably the easiest but probably difficult to imagine. But probably this is the simplest and the fastest approach for reaching the internal iliac. You will wonder how can it be extraperitoneal, you can reach its fastest. Believe me, it is fastest. I will give you an example at the end. It is useful in carcinoma cervix and CA vulva, particularly when we used to do radical vertebral cystectomy, and it was a different method I always used. I did it with financial incision, unusual to the recommended vertical incision, which extends even above the umbilicus. But I used to do it with financial incision, a wide financial incision, and then I used to dissect the lymph nodes extraperitoneally. Before opening the peritoneum, I used to approach all the pelvic structures extraperitoneally, dissect all lymph nodes even up to the common iliac, down into the obturator fossa and everything, and then open the peritoneum and then remove the uterus. This gave me a chance to ligate the uterine artery at its origin, because I exposed it completely. Now this was a very difficult approach, nobody accepted it, but I continued to do that, and I was happy because the pelvic node dissection, there was no interference of the intestines. The only thing that lacks in this procedure is you cannot evaluate the parametrium, but that parametrium evaluation is now easy because of the imaging science. So it is not used routinely, but very simple approach. The umbilical artery arises from anterior division of internal iliac. Now going back, let's sit in the time machine and go back to the embryology. Let us imagine where the obliterator umbilical artery arises. It arises from the internal iliac artery. Can you identify the obliterator umbilical artery? As soon as you separate the muscles before entering into the peritoneum, you definitely see bilateral both umbilical arteries, which are the thick fibrous bands, which are fanning outside into the pelvis. It is easy to trace it extraperitoneally and leads us directly to the anterior division of internal iliac. So just lift it with the Alice's forceps and trace it and dissect the peritoneum along the pelvic wall to trace that obliterated umbilical artery, and the moment you complete your dissection up to the pelvic wall, you see the internal iliac anterior division in front of you, from which the obliterated umbilical artery is arising. So it is as a simple benefit of anatomy you are taking, and this is the fastest and simplest approach. It is faster approach than intraperitoneal. Believe me, it is faster approach than intraperitoneal. Intraperitoneal, you are always worried about where I am going to near the ureter. Ureter is the biggest threat to the gynecologist, particularly a gynecologist. And ureter is not a kind organ, I tell you. As sir has already told, bladder is a very kind organ. But I will come to that later on. But ureter is not a kind organ, so you are always worried of the ureter. But when you are dissecting extraperitoneally, as you keep on lifting the peritoneum, the ureter automatically shifted along with it medially. And you realize only when you do it. It's very difficult to imagine, but as you go dissecting the peritoneum, extraperitoneum, the ureter automatically shifts medially and the whole tree of common iliac and its all branches is exposed very nicely. So it's not difficult. You have to remove the mindset that it is difficult. Even if the peritoneum is open, it is very easy to approach internal iliac extraperitoneally. I routinely do it whenever I am called for some emergency help. This is the anatomy. As you can see, common iliac. This is the inferior epigastric. This is the internal iliac, external iliac going out, internal iliac, the posterior branch, anterior branch. I will magnify it a bit. And then here you can see the internal iliac, the posterior branch, the anterior branch, and now you can see the obliterate umbilical artery that takes a round around the pelvic wall and goes into the peritoneum anteriorly. So this is a simple anatomy you are taking advantage of. You trace it downwards, go at extraperitoneally, and you reach the internal iliac anterior division. Fastest and simplest approach. Intestines don't bother you. You don't have to pack the intestines. Even if the abdominal peritoneum is open, just approach externally, the intestine will keep away itself and the internal iliac is in front of you to ligate. In minutes, you can reach the internal iliac. So this is about approach, extraperitoneal approach to internal iliac. Posterior approach is a bit difficult on opening the peritoneum posteriorly. Identify the psoas muscle. This was depicted by nicely in lecture. And ureter is identified attached to the medial peritoneal reflection. Fibrofatty tissue is dissected, internal iliac artery is opened and on the surface of the artery. As I told you, ureters are retracted medially. Sheath over the artery is opened longitudinally. A mixture artery is carefully. If you really want to see a beautiful video, Pankaj Desai sir has posted on his YouTube channel, internal iliac artery dissection. It's a beautiful high definition video. It's a only 1.5 minute video. When I was searching for the material around, I found this YouTube video of sirs. And it's a beautiful video. Just log into his YouTube channel. Find out the internal iliac artery ligation. It's a 1.5 minute and beautiful dissection he has depicted in that film. Ligation is performed 2 cm distal to bifurcation to avoid disrupting the posterior division of hypogastric artery. This is very important. You should not accidentally ligate the posterior hypogastric. Coming to the complications, this is about the procedure. I will explain in my case experience again. Apart from a broad ligament hematoma not increasing in size, no major complications are noted. The chances of ureteric injury are lower as sutures are placed much higher. Even in step 2, as bladder is dissected low down, ureters fall lower, hence less chances of injury. Now this is difficult to imagine how it happens, but when you are actually doing it, you can experience it, that how the ureter goes away if you are not really afraid, and if you are really careful and keep honor of the ureter, you can see that ureter helps you by going away. The chances of ureteric injuries can be minimized by exteriorizing the uterus and pulling it on, as I already told you, on opposite side, so that the distance between the ureter and the uterine artery increases. It is difficult when tissue edema is present. Injury to ureters and vessels is the complications. It takes more dissection time, and this more dissection time is avoided in extraperitoneal dissection, and you will believe it when you perform it as a comparative study. More experience is required for internal ligation. Thromboembolism chances very remote actually. Increased need for blood transfusions and gluteal region necrosis if accidentally you ligate the main branch. This is a picture in short. This is the internal iliac where it has been ligated. And I will come down to one more picture where you, in systematic devascularization, you start ligating this first as a ascending branch of the uterine, then uterine, and finally you go to the iliac. Coming to the last slide, as I told you, it's a very short but very sweet and very important topic. You know, everybody wants to jump on the laparoscopic. What is the role of laparoscopic internal artery ligation? In case of establishment where laparoscopic facility is at hand with expert endoscopist, using them and to avoid laparotomy, feasibility of laparoscopic internal iliac ligation should be explored. So it is not contraindicated. It can be done laparoscopically. And now you see many experts like Sandesh Kade who are working with high definition cameras, and in their demonstration videos they show the pelvic anatomy so nicely, and that it's not difficult to identify the internal ligate it with the help of the laparoscopic instruments. It has advantages of being minimal invasive and less time consuming if surgeon is expert. The learning curve is of course very high, you need a lot of expertise, and there should be no accidents while doing this. Well, this brings me to my own experience and importance of internal ligation. In the middle of the night I had a call from one establishment, one tertiary care center. It was a case of placenta accreta. They had already done subtotal hysterectomy, and still the bleeding was not stopping. So they called for help, and I went up there. A surgeon was already there because the bladder was injured. Bladder was already open, and it was sutured, and that I will tell you the sequence how it happened. And when I reached there, there was torrential bleeding from the whatever the subtotal hysterectomy was done. Nothing was stopping. So immediately as I decided to remove that, they had packed it completely till I reached there. I removed the pack, and the taps started bleeding heavily. The anesthetist was somehow maintaining the balance and maintaining blood pressure at around 90 and 100, and still the bleeding was extensive, torrential bleeding. So I decided immediately to go for iliac ligation. We explored iliac ligation, iliac on both sides. We ligated them effectively, and the bleeding really stopped. But the patient by that time had already entered into irreversible shock, and the patient died after 6 hours. Now what went wrong here? I tell you what went wrong here. The decision of iliac ligation should have been taken first. When the bleeding was there, torrential bleeding from the stump was there, they were busy in repairing the bladder. Now, sir has already told you, bladder is a very friendly organ. You insult him, but you apologize to the bladder, and bladder helps you. Bladder doesn't bother you. There are 2 organs in the abdomen which least bother you. One is the small intestine, and second is the bladder. You can insult them, but then apologize them, and they are friendly with you. You damage the colon, you are in trouble. You damage rectum, you are in trouble. But these 2 organs will never bother you if you honor them properly, if you identify the injuries done by you properly. So what should have been done in that case? We could have, that was a preventable death, definitely. I did not comment at that moment, but then when the surgeon asked me, sir, what went wrong? I said, you shouldn't have repaired the bladder first. Bladder would have been repaired, even you can repair it even after a day, doesn't matter. But you should have opted for internal iliac ligation first, and then you should have looked for other bleeding somewhere, what recorrective measures you could have done. So that was my first-hand experience how important internal iliac artery ligation is. Dear friends, thank you very much. After the highly inspirational lectures from our key speaker today, all three beautiful lectures, this was probably a high and dry lecture, but thank you very much for your patient listening.
With this, we all know that internal iliac ligation is how important in our clinical practice. With this, we can save the uterus. So, thank you, sir, for your great lecture. Thank you.
Thank you, sir. I request chairperson to please felicitate Dr. Pankaj Desai, sir, and Dr. Kumtekar, sir.
Prophylactic ligation in...
Say cervix burdens before they...
No.
They sometimes are good, but now they are going in for embolization. But that is very expensive, sir. Nobody can. Very few people can afford it.
I request Virkar sir to felicitate Dr. Baldwa sir and Dr. Lata Patil.
I am very happy to deliver the vote of thanks. I thank from my bottom of heart today's eminent speakers, Dr. Pankaj Desai sir, PK Shah sir, Vidyadhar sir, and all the speakers and all the teachers. I thank from my bottom of heart and declare as the program is finished.